Mhm. No. Okay, good morning. How is everyone doing? Can everyone hear my voice? Okay, thank you so much for your kind cooperation for starting the lecture a bit late for today. First of all, let me apologize for taking so much of your time. I know it's really valuable for you all since you guys are preparing for your assembly step one. Okay, having said that, we will try to finish in due time today. And it's not like that we would try to cram up all the information and cram it all up in the short span of time. We will be doing the appropriate time, that is 4 hours, and hopefully by 1:30 we'll be done with our regular topic. And thank you so much for your well wishes for my father. He's doing pretty well till now. Okay, that's what it is. Please keep us and my family and my father in your prayers. um, Having said that, how was how many questions did you guys solve in your U world? The same question I keep on asking you guys every day. How many questions are you guys solving in U world every day? Can I get some answers from everyone, please? 30, very good. 4, 15, 30, 20, 20. Okay, that's very good. Okay, that's great. That's actually very good. Okay. Okay, do not worry if you need a long time to go through the explanations. Okay, as long as you keep on doing the questions and you keep on understanding what they are talking about, that's enough. Okay. So having said that, since we are a little bit since we are a little bit late today, okay. So the thing is, so first of all, let me start the lecture today by sharing the email ID and password for Dr. Najib. Okay, so the thing is, we wanted to choose 5 students every week. Okay, so for the first 5 students, uh, who are the students over here right now who's interested to view the lectures from Dr. Najib? I know I got a lot of emails. Okay, but do we have any active students over here who is interested to view the ID? I mean the lectures from Dr. Najib. Do we have any students over here right now who is interested to view the lectures from Dr. Najib? Not right now. I will share the email address and the ID with you guys on your email, but I just wanted to see if you guys were actively interested right now, because if you guys were, then I would have sent you the email ID and the password. Okay, so no response. So what I would do is I would just send the email ID and password to the students who reached out. Okay. Having said that, okay, good. So having said that, are we ready to do a small revision and recapitulation of the yesterday's lecture very quick to see where we stand? Okay, good. Okay, then let's start with our daily revision and recapitulation very fast, and we will try to we will try to we will try to reach a bit of the difficult topics of psychiatry today. By that I mean high yield topics. Okay. So before we do that, let's start with the revision. First of all, what I wanted to know is if you have to have learnings, okay, the learning could be done in with two types of conditioning responses. If the response is due to an is usually elicits an involuntary response, what is the type of conditioning? Very good. If it elicits a voluntary response, then what type of response? What type of conditioning is this? Okay, 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 good. So if you want to increase or decrease a behavior, what is the term used for increasing or decreasing a behavior? Very good, reinforcement. Okay. How about if you want to decrease a behavior? Punishment. Okay. And if you want to get rid of the behavior? Okay, extinction. Very good. Can we talk about the ego defense mechanisms? How many broad, how can you broadly categorize the ego defenses? 2 categories. Very good. One is your immature, another one is mature. Very good. Okay. First of all, if a patient comes to your office and starts shouting at you for no reason because you were a bit late to start his appointment, What is this defense mechanism? Acting out. Okay. If uh, if a patient just got diagnosed with cancer, but he is working full time to avoid the whole diagnosis. Okay. If a husband comes back home and shouts at his wife because he was shouted on by his boss. Okay, good. Okay. Next one is next one is next one is, let's say that a surgeon, while doing an operation or performing an operation, okay, he gets angry and he starts throwing things at the residents because he used to do the same thing when he was little. Fixation. And what about a surgeon? When he loses a patient, he starts crying. A surgeon, he loses a patient on the OT table and then he starts crying. Regression. Very good. That is a regression. Okay. Okay. If you have a resident who thinks the world of his attending supervisor, what is this immature defense mechanism? Idealization. Very good. A patient who just got diagnosed with carcinoma, if he tries to explain the disease to everyone who asks him his diagnosis, what is this? Okay, very good. Next one is, if you have a friend who asked you how you dissected the cadaver, and you did not skip out on any of the gory stuff, and you told her everything. Isolation of effect. Very good. Okay. Okay. Let's say right now your wife is mad at their husband, and when the husband comes back home, instead of shouting at the husband, the wife forgets to intentionally forgets to give him dinner. Passive aggression. Okay. Okay. By that, I do not mean that wives are supposed to provide dinners. That's not what I mean. Okay. Okay. Husbands are supposed to provide dinners to wives. Okay. And vice versa. Okay. It's a co-job. It's a co-job. Everyone should work in the home together. There is no division of work. Okay. So just putting it out there. Okay. Next one is, if you have if you have a student who failed an exam, and after failing the exam he tells everyone that it wasn't important to him. What was okay, good. Rationalization. Okay, good. Okay, good. Next one is, you have a patient when you are good to him, he thinks the world of you, and if you skip out on one of his appointment. Okay, splitting. Are you guys okay? That's absolutely brilliant. Okay, how many of you guys are looking at the book right now and answering? If you guys are honest, I'll give you a 90% discount on my lectures. Okay, so I believe you. Okay, every one of you guys. Okay, I believe you guys. The reason why it's a bit hard and difficult to believe you, it's because you guys are absolutely brilliant for answering all these questions from your previous knowledge. Okay, from your previous knowledge. Yes, Dr. Iman, what is your question, please? What is your question? Yes, Dr. Iman, what is your question, please? Okay, so crying is not an immature response. Okay, let me get the okay. So the thing is, crying is not an immature response. Crying is a very healthy way to let your grief out. Okay, but the thing is, if it's an immature response when it's an immature response when an adult starts crying for something which is generally not should not be as upsetting. Let's say a surgeon who loses his patient on his OT table. Of course, it's a very difficult scenario for that surgeon. Okay, but as an attending surgeon, he has residents working under him, and he needs to hold his ground, and even he knows that, and that's his job as a supervisor. So he needs to set the right example for everyone. So even if he feels bad, the matured way to deal with this is either by suppression or sublimation. Okay, so that's the more matured way to deal with it. Okay, But if the attending supervising surgeon starts crying in front of everyone, okay, that's an example of an immatured response, immature behavior. So that's what it is. That's what I meant basically. Okay. So hope that answers your question. Next question is, there the difference between fixation and regression? That in fixation you get aggressive, in regression you are sad and cry. Okay, no, that's not the thing. The thing is, fixation means that one of your immature behavior has been fixated into your adulthood. Okay, one of your immature behavior has been fixated into your adulthood. So let's say as a child, every time the food was late, every time your food was late, you started shouting at the person who was responsible for making your food. Okay, so a lot of childs throw certain tantrums. Okay, but as we keep on growing older and into our adulthood, we realize that that is not the appropriate response, so we stop doing that. But what if you do not realize that and you still keep on doing it? That's an immature response. Okay, so that is fixation. Regression is basically every time something goes wrong, you regress to your immature response to get more, because a lot of the times the young children, they do certain things to get more attention, okay, than other people, and as a child that is completely normal. But if you keep on doing it when you are an adult, that if you have to respond to a certain scenario and you regress to your immature self to get more attention, okay, that's an immature response, and that is regression. Okay, next question. You are stuck in one age group. Okay, so Dr. Tarian, would you please elaborate your question? Okay. Oh, it was about fixation. Okay, good. Okay, so that's what it is. So the next type of the next type of defense mechanism that I want to talk about is, you have a teenager who is angry at home, but instead of taking out that anger on anything else, he goes to the gym and he starts working out, and he channels it into his workouts. That is sublimation. Very good. If you have a mafia boss who feels bad for earning, okay, altruism. Okay, good, very good. Okay. Okay, very good. Okay, how about a student who just got out from his USMLE Step 1 exam? He's nervous, but instead of being nervous, he jokes about his exam. Okay, humor, very good. Okay, and another one is, how about this USMLE Step 1 student, after he's done with his exam, he comes out of his exam, and when he is asked by his peers about how hard the exam was, he tells them that it's better to think about the exam when the results are out. Okay, depression. Very good. Okay. Okay. So how important do you think are these ego defenses terms are? Ego defense terms are very, very important. Very good. Okay. That is very important. Very important. Okay. So what we can do is, what I would ask you guys to do is, if possible, please take a picture of these two pages that on first aid in your phone, or if possible, print it out and post it on your wall. Okay, so studies have shown that people who want to learn something involuntarily, okay, if they have certain texts which they want to master, if they have walls in their rooms which they look on from time to time, if they have those informations over there, then they can review themselves from time to time. Okay, so that's what I used to do when I used to master, when I wanted to master something. What I would do is I would just like take a picture of it in my phone every time I was at the subway or going somewhere else. Instead of looking through Instagram or anything else, I would just look at my texts. That's what you can do. Or if you stay home all the time, please take pictures, print it out, post it on your wall. Okay, and then you can keep on looking at it, because this is extremely important. Next one is, one question to acting out. The example of first aid is confusing because this example you could use for passive aggression too. Okay, let's see which did first aid use. Let's see the example used by first aid. First aid used the example that a patient skips appointment after deep discomfort after dealing with his past. Okay, so basically this patient over here is acting out, not on the this patient over here, if you guys look at the example of acting out in first aid, okay, so this is an example of the patient who is acting out on himself. He is not acting out on he is not acting out on the physician. Okay, so since he is not acting out on the physician, this is not passive aggression. Since he is acting out because he cannot deal with a certain stressor, previous stressor that causes him discomfort, that's him acting out on himself. Okay, so that's that. Okay, good. Okay, let's move on. Next one is what I would want you to know. What I would ask you guys is, okay, if you deprive an infant, of course not. Okay, you should not be sorry for questions. Questions are the reasons our lectures are here. Okay, or else you guys could have read first aid by yourself. Okay, so please ask as many questions as you need. Okay, no apologies. Next one is if I ask you guys that how long can you deprive an infant void of love or affection or and care? How long do you think the infant can survive without irreversible changes? 6 months. Okay, that is important. Next one. If I ask you about child abuse, how many types of abuse do you think there are? Three types of abuse. Very good. If I tell you that you have a set of parents who comes to you, you're a pediatrician, and the parents are extremely concerned about their child with a common cold because they lost a previous child to flu or to a virus. What is this syndrome called? Vulnerable child syndrome. Very good. Vulnerable child syndrome. And now let's talk about the important stuff. First of all, I want to talk about ADHD. Okay. ADHD. What are the criteria? First of all, I want to talk about the age and I want to talk about the duration. So, age should be before 12. Duration. How long should the symptoms last? 6 or more months. Okay. 6 or more than 6 months. Next one is if you have a child on the spectrum, okay, and if you have a child on the spectrum, what are the criteria you're looking for in the child? And by that, I mean child on the spectrum. By that, I mean child with autism spectrum disorder. Repeated behavior, very good. Okay, okay, good. Okay. Next one is you have a child who comes to your psyche clinic, and the child's mother complains that she gets a lot of complaints from the school that the teacher keeps on telling her that her young boy has a habit of destroying school property, putting things on fire, harming little animals, conduct disorder. And if this thing is not solved before the age of 18 years, what is the next psychiatric disorder that this might lead to? And antisocial. Very good. Very, very good. Okay, absolutely brilliant. You guys are doing amazing. Okay, it surprises me how easy it is for you guys. It wasn't as easy as it is for you guys as it was for me, to be honest. Like these things were extremely difficult because we were not taught these things during our bachelor's. Okay, very good. Next one is if you have a child who comes to you, okay, with his mother, and the mother complains that every time they go on flight, the child has extreme outbursts of crying and throwing tantrums. DMD, very good. DMD, okay, good. Another one is if you have a child who keeps on repeating the grade over and over again for the next almost 3-4 years, that's ID. By ID, Dr. Tani means intellectual disability. Very good. Okay. Next one is if you have a child who has a problem with authority, every time the teacher asks him to do something, he doesn't do it. Oppositional defined. Very good. Next one is you have a child who starts talking suddenly out of nowhere at the age of 7 years. Okay. But he did not talk till then. Self selective mutism. Very good. Okay. Next one is you have a young child who cries every time his parents are late to pick him up from school. Okay. What is this disorder? Anxiety or separation anxiety. Okay. And if it's a separation anxiety disorder, okay, if it's a separation anxiety disorder, I should have mentioned the age, okay, but how about you guys mention the age for me? What is the age of onset for separation anxiety? Is it abnormal to have separation anxiety at the age of 2 to from from 3 to 4 years. Okay, no. So 3 to 4 years is normal. More than 4 years, it's abnormal. And how long should the symptoms last in order to get diagnosed as separation anxiety disorder? 4 weeks or more. Very good. Okay, 4 weeks or more. Okay, next one. Next one is a child is doing excellent in arts, but he, for some reason, he has been failing maths for the last many years. Okay, SLD, SLD or specific learning disorder. Very good. Next one. Next one is if you have if okay, so the next one is you have a guy who comes to your office and tells you that every time he goes out on dates with girls, he cannot stop making unnecessary comments and slangs, and it comes out of nowhere. Coprolalia or Tourette syndrome. Okay, very good. If you have to treat Tourette syndrome, what is your number one approach? What is your number one approach? Haloperidol is not the number one approach. The number one approach is psychoeducation, behave CBT. After that, we have haloperidol. And there was another important autonomic drug which we mentioned. That is very good. Alpha 2 agonist. Very good. Okay, alpha 2 agonist. Okay. Next one is if you have to diagnose a patient as psychotic, what are the three criteria you have to look out for? What are the three criteria? Delusions, hallucinations, and delusions, hallucinations, and disorganized speech. Very good, Dr. Mon. Okay. Anyone else? Disorganized and disorganized thought. Okay, Dr. Nawud, Dr. Basi, Dr. Hussain. Yes, disorganized thought. That is what it is. Okay, so that's that. And having said that, okay, we will not discuss anymore. We will jump into our new topic for today. Okay, we will jump into our new topic for today. That is the first thing that we want to discuss today is at first. Give me 1 second to share. Give me 1 second to share my screen. Okay. Is anyone over here a fan of The Good Doctor? Anyone over here who's a fan of The Good Doctor? Okay, good. Doctor. How about now? Is the voice better now? Okay. Okay. Oh, so what I was asking was, is anyone over here the fan of The Good Doctor? Has anyone heard about the show, The Good Doctor? Anyone? Oh, it's an American show right now. They made a American spin-off to the Korean version. Okay. Okay, good. Okay. Uh, do you guys have any idea though? This question goes to the students who has watched The Good Doctor. Do you guys have any idea what the diagnosis of the main character is? Autism. Very good. Okay. Autism. Okay, you guys should watch. If you guys are a fan of watching TV series, that's a TV series for physicians that I would like to recommend. It's an amazing TV series about a young surgical resident over here in San Jose who has been diagnosed with autism spectrum disorder and Asperger's syndrome, who can view things and view complex anatomy and solve amazing cases. Okay, that's that. Okay, having said that, I'm done. Let's start. Okay. Okay, good. So can you guys see my screen properly? Can you guys see my screen? Can all see my screen? Okay, is the voice okay? Okay. If everything is great, then let's begin. Okay. I'm very excited for today's lecture. Okay, so the first thing that I want to talk to you guys about today is schizophrenia. So we have started talking about the diseases in psychiatry, the pathologies that are related to psychosis. Okay, So that's that. Okay, so one second. So first of all, we have to talk about schizophrenia. This is one of the most high yield topic for USMLE step one. Okay, and schizophrenia. Okay, if I have to tell you how important schizophrenia is very very important. Okay, schizophrenia is very very important. Okay, so first of all, what is schizophrenia? Schizophrenia is basically a chronic illness which can cause profound functional impairment. Okay, so it's a chronic illness which can cause profound functional impairment, and the symptoms can be categorized into broadly three broad categories. Number one are the positive symptoms, then you have the negative symptoms, and then you have cognitive symptoms. Okay, so in order for us to do that, okay, in order for us to understand what schizophrenia is, let's talk about this in our white page over here. Okay, so first of all, we are talking about schizophrenia. Okay, okay. So we're going to talk about schizophrenia. Okay. Okay. So number one are the positive symptoms. Okay. So we have three symptoms broadly categorized for schizophrenia. Number one is the positive. By positive, okay, by positive, what psychiatry means by positive symptoms are when the patients are very hyper. Okay, so if you have heard about drugs, okay, so drugs in general are, we can it could be classified into two types of drugs: recreational drugs. If you have to classify drugs, it can be classified into two types of drugs. That is, how about now? Is the voice okay now? Is the voice better? Voice not better? Okay. Okay, how's the voice now? Is the voice better now? Okay, good. Good. Okay. Okay, so let's start once again. First of all, what I was talking about was I was talking about the fact that if you have to have recreational drugs, okay, recreational drugs are basically of two types. Okay, there are uppers and then there are downers. Okay, and by that I mean you have drugs such as cocaine, then you have drugs such as LSD, then you have drugs such as methamphetamines. Okay, these are your upper drugs, meaning that these are the drugs which will make you hyper happy, more active. Okay, and these are basically like party drugs. I mean that like when you are on it, you wouldn't want to sleep and relax. Okay, PCP is also one. Okay, phencyclidine. Okay, and then you have drugs such as marijuana. Then you have drugs such as heroin, more opioids, right? Then you have drugs which will make you down, like which will provide that type of feeling where you just want to lay back and relax. Okay, so that is, so these are basically the two types of drugs, and based on that you have your symptoms over here. Okay, so first of all, you have your symptoms over here for schizophrenia. The positive symptoms for schizophrenia are: number one, what happens when you are really really happy and you are paranoid, I mean when you are extremely hyper. Okay, so you start seeing things that do not mean the same way. So first of all, you get you get a false perception of reality. Okay, so first of all, the one of the most positive signs are delusions. And what are delusions? We talked about this yesterday, that these are false perceptions of the reality. This could either be delusions of grandeur, jealousy, persecutory, somatic, mixed. It all depends on the patient. Next one are your hallucinations. Okay, next one are your hallucinations. So you have your positive symptoms. Then that is also a type of symptoms which the patient will experience if the patient is extremely hyper. Okay, next one is unusual. Next one is unusual thought. Unusual thoughts. Okay, what happens when you're extremely hyper? Okay, let's say you are extremely hyper right now, you would make impulsive decisions. Okay, you would make absolutely impulsive decisions. If anyone asks you when you are extremely hyper, If anyone asks you, if you're extremely hyper and they ask you that, okay, do you want to jump off the bridge, and for some reason at that point it sounds like the best idea to you, and you literally jump out of the bridge. So that's an extremely unusual thought. So that's that's unusual thoughts. Next one is pressured speech. Okay, pressured speech. What do I mean by pressured speech? Meaning that you do not need to speak to anyone, or you do not need to talk to anyone about anything important in particular, but you feel the need to talk, and you keep on talking. Okay, and at one point it feels like it's being pressured. At one point it feels like you are being pressured to talk. So this is known as pressured speech. Okay, and the last one is bizarre behavior. Okay, the last one is bizarre behavior. Okay, so okay, so are we clear on the positive symptoms? Are we clear on the positive symptoms about why these symptoms are happening? Okay, first of all, think about all the positive symptoms when you are hyper. Okay, when you are hyper, you see things that are not there. Delusional. And I mean, you perceive things that are not there in reality. Delusional. You see or hear things that are not there. Hallucinations. Okay. After that, you feel the need to talk to everyone. Disorganized speech. After that, you feel the need to do anything and everything. That is unusual thought. Okay. After that, next group of symptoms for schizophrenia is the negative symptoms. And now your negative symptoms are the effects which are the same as the drugs, which are downers. Okay, so what are the effects? The effects of negative symptoms. Number one is flat effect. Flat effect. What do you mean by flat effect? Flat effect basically means that no matter what anyone tells you, let's say if anyone comes and tells you that, okay, we should run, there's an earthquake, and you just look at that person with a blank look on their face, and with a blank look on your face, and just tell them, okay, whatever. Okay, you do not you seem to forget the importance of an earthquake. So that's what it is. Okay, so that is flat effect. No emotion is actually not correct. I'm going to tell you why. Okay, that's a good thing you mentioned that. No emotion is basically what would happen is if you say negative symptoms, patients have no emotions, then you would have to exclude the fact that these patients can undergo long episodes where they keep on crying and weeping. Okay, so that's a sort of emotion. So no emotion would be a bit incorrect. Flat effect is a very appropriate word for negative symptoms because basically their responses are all flat. Okay, that's the thing. They look like they have no emotions, but basically it's just the effect of the disease. That's what it is. So flat effect. Next one is apathy. Okay, who knows what this word apathy means? Apathy. Apathy. What does apathy mean? Very good. No empathy. Okay, that's what it means. What do you mean by empathy? What do you guys mean by empathy? Empathy. Okay, basically empathy. An example could be, let's say you see let's say you see someone in distress and you feel bad for them. Okay, and you want to help, and you want to help them out. That's a sort of example for empathy. So basically feeling for others or concerns for others, those are all the same. Okay, next one is hey anhedonia. Okay, what is anhedonia? What is anhedonia? Okay, so lose. Okay, inability to experience pleasure. That is one another thing. Loss of interest in daily activities. Okay, so that is another one. Okay, next one. So have you guys understood this? Loss of interest. That is correct. Okay, so that's what it is. Okay, loss of interest. Okay, next one is, okay, what is the next one? The next one is allogia. Okay, apathy and hedonia and allogia. Okay, so what is allogia? What is the next one? Allogia. Okay. Okay. So basically, lack of interest in making a conversation, or lack of interest in talking to anyone, or thinking in that matter. So it's a very It's an excellent term for basically meaning that if someone wants to make a conversation with you, I'm sure there has been a lot of times with each and every one of you when you just look at that person and you literally do not want to talk to him or talk to her. Okay, so that could be because of anything else, but also because of the fact, because it's not because you cannot talk, it's because you choose not to. Okay, so allogia. Okay, so that is the next one. Next one. Now, the after that we have another one. Okay, the last one is very easy to understand. The last one is social withdrawal. Okay, last one is social withdrawal. Okay, so the reason why I'm taking my time to break down these signs and symptoms is because you have to understand these things from the questions. Okay, so if you don't understand each and every term in the negative and positive symptoms, then you cannot diagnose a patient with schizophrenia. So that's what it is. Okay, next one. The last one is, okay, so we have the positive symptoms, negative symptoms. I'm pretty sure you guys know what social withdrawal is. Okay, basically withdrawing oneself from the whole society. That's social withdrawal. Okay, the last one is cognitive. What is cognitive? Cognitive is cognitive dysfunction, or reduced cognitive ability, meaning the reduced ability, okay, decreased ability to make plans or working memory. Okay, to make plans or working memory or working memory. Okay, you do not want to think about. Okay, you do not want to think about. You do not want to think about. You think about something. You do not want to make plans in anyone. Okay, you do not want to solve any problems. Okay, that's what it is. So these are the three broad categories of the disease, that is schizophrenia. Next one is, if you want to diagnose schizophrenia, okay, if you want to diagnose schizophrenia, the diagnosis, it usually requires two or more of, okay, two or more of these symptoms. Okay, so you have another group of symptoms. Okay, and these symptoms, they are, okay, number one, you have delusions. So these symptoms could again be categorized into five. Okay, this is where it gets a bit confusing, but it's easy to understand. That first of all, if I ask you what are the three categories in which psychosis can be, I mean the three broad symptoms of psychosis. You guys have just answered this 1 minute back. What are the three broad categories of psychosis? Very good. So delusions, hallucinations, and disorganized speech. Okay. Okay. So basically, delusions, hallucination, disorganized speech. Okay. Then we have another one, that is disorganized behavior. Disorganized behavior, or we have negative symptoms. Okay. So basically, if you want to diagnose a patient with schizophrenia, there is a criteria. Okay. The criteria has to be met in order to be diagnosed as a schizophrenic patient. What is the criteria? The criteria is, okay, the criteria is, it requires two or more of these following symptoms. Okay, it requires two or more of these following symptoms. So let's say two or more. So let's say the patient has delusions and hallucinations. That's two. If the patients have delusions or hallucination, okay, and along with this, the patient also has disorganized speech, so that's two or more. So you either need two or more of these symptoms, or the patient can have symptoms such as these first three, because the first three are the main domains of psychosis, that is delusions, hallucinations, and disorganized speech. So either the patient can have two or more of these symptoms, or one, or these three altogether, for at least 1 month or more. For at least 1 month or more, for as long as 6 months. Okay, try to understand. I will break it down once again. I know it's a bit confusing. Okay, I will break it down for you, but just let me finish the lecture. Okay, and the onset has to be, okay, the onset has to be 6 months Okay, 6 months or more prior to diagnosis. Okay, now what's happening over here? First of all, what did we do today? First of all, we learned about schizophrenia, that schizophrenia is a psychiatric illness. Then we learned about the positive, negative, and the cognitive symptoms that we see in psychotic patients. So we have the positive ones, negative ones, then we had the cognitive ones. Okay, now we are back to schizophrenia. If we want to diagnose a patient with schizophrenia, we have to look out for we have to look out for these five broad symptoms. The five symptoms are delusions, hallucinations, disorganized speech, disorganized behavior, and negative symptoms. Okay, now we have to discuss about the criteria. What is the criteria? Criteria is, in order for you to diagnose a patient clinically as schizophrenic, the patient has to have either two or more of these five symptoms, or symptoms from one to three, okay, for a period of 1 month or more. If it's less than 1 month, then it's not schizophrenia. Okay, it has to be from, these symptoms have to last for 1 month or more, and it has to last for 6 months. Okay, and it has to last for 6 months, and let's say after 6 months these symptoms disappear, these symptoms they disappear, that then it still won't be schizophrenia, it still could be something else. So this has to last for 6 months and exactly prior to the diagnosis. Okay, so prior to the diagnosis, so let's say it, the main thing is 6 months or more. If I say 6 months or more, then everything becomes easy. Okay, so 6 months or more. So once again, the diagnosis is from two or more of these symptoms for, or one to three of these three symptoms for 1 month or more for a period of 6 months or more. Have we understood this? Yes or no? Are we confused? Anyone? Any confusion regarding the diagnosis? Confused about the time? Okay. First of all, in order for you to diagnose a patient with schizophrenia, the patient has to have either delusion or hallucination. Okay, so that's two. Or the patient can have, or the patient can have delusion, hallucinations, and disorganized speech. Okay, okay. And the thing is, if the patient has these symptoms for 1 month or more, okay, then the patient is at risk of developing schizophrenia. And then the patient has still not developed schizophrenia. So what would happen is these symptoms need to last for 6 months or more than 6 months. Okay, 6 months or more than 6 months, and actively they have to last for 6 months or more than 6 months. So that's what it is. Okay, so if that happens, then the patient can be diagnosed as a schizophrenic patient. Are we clear now? Are we clear now? Okay, okay, good. Okay, now there is another disease that I want to talk about very quickly. Okay, if you have a patient in which these symptoms, for let's say you have a patient, in which you have um, okay, so first of all, delusions, hallucinations, and disorganized speech and disorganized behavior, are they negative symptoms or positive symptoms? Are they negative symptoms or positive symptoms? Positive symptoms, very good. So the, okay, so they are positive symptoms. Okay, there is another disease I want to talk about really quickly. Okay, this disease is, okay, this disease is called BPD. BPD, by that I mean brief psychotic disorder. Brief psychotic disorder. So what would happen in a patient with brief psychotic disorder is that one or more of these symptoms, that is the positive symptoms, okay, one or more of the positive symptoms. So it could either be one or more than one, okay, one or more than one, okay, and these symptoms can last for less than 1 month, okay, less than 1 month. If that's what happens, that let's say you have a patient who only has delusions or who only has hallucinations, and these last for less than 1 month, and after 1 month this whole thing resolves and there's no problem, then this disease can be diagnosed as brief psychotic disorder. Brief psychotic disorder. And the number one cause of brief psychotic disorder is the number one cause of brief psychotic disorder is stress. Stress. Okay. The number one cause of brief psychotic disorder is stress. And if I have to share from my personal experience, okay, from personal experience, I literally knew this one friend of mine, okay, more of an acquaintance, less of a friend, okay. Okay, he was so obsessed with doing well in his USMLE step one, okay, that he literally got diagnosed with BPD. What happened was he was extremely obsessed. So what he did was he did not sleep straight for 3 4 days. Okay, he wanted to finish first aid in 3 4 days, do U World, everything, and his goal was to finish everything in 1 week. And that's what he aimed for, because he wanted to aim for that score, that is 260 to 70. And in order for him to do that, he put so much stress on himself. He had lack of sleep. Okay, and he literally ended up being in the hospital. Okay, he had to be hospitalized. He had to be hospitalized because he had a very big meltdown. Okay, he got aggressive. Okay, he got very aggressive. He had a meltdown. Okay, and then he started having these exact positive symptoms, delusions, hallucinations, and stuff like that. And you can understand that the visual and auditory hallucinations are very common in a patient who has not slept for 2 or 3 days. Okay, so that's that by itself. So that's what it is. Okay, so do not get so stressed out with with your exam that you have to be admitted to the hospital psychiatrically. Okay, but at the end of the day, he did very well nonetheless. Okay, when he got out, he took some time. Okay, he actually did very well in his exam. So that's what it is. But having said that, he did not have to get admitted to the hospital and put this extra stress on himself and his family. That's what it is. Okay, so brief psychotic disorder is my friend who is extremely worried about who was extremely worried about his exam. He put so much stress that he got admitted to the hospital because he had delusions and hallucinations. So next time you come across this type of scenario, think about my friend. Okay. Next one. Next one is what if I tell you, that you have symptoms? Okay. What if I tell you that you have symptoms such as delusions, hallucinations? Okay, delusion, hallucinations, two or more than two. So let's say the patient also has disorganized speech, so three of the positive symptoms, but the patient has the symptoms between 1 to less than 6 months. Okay, is that a possibility? Yes or no? Is that a possibility? Yes or no? Yes, that's a possibility, and Dr. Tarin was kind enough to let us know the answer. And the answer is, this disease is known as schizophreniform disorder. Okay, schizophreniform disorder. Okay, how many of us are fans of Pokemon? Do you guys remember watching Pokemon when we were little? Okay, how about Digimon? Okay, good. Okay, do you guys remember that we had Pokemon? Okay, is there anyone else who has not watched Pokemon? Anyone else who has not watched Pokemon? Okay, Dr. MS. Okay, so okay, Dr. Adam. Okay, so basically Pokemons are cartoons. Okay, Dr. Dahlia, no. Okay, no. Okay, good. Okay, so so the thing is, Pokemons are basically, what are Pokemons? Pokemons are basically, you have this one animal, okay, and then this animal turns into another big animal, and then it finally transforms into another big animal. Okay, that is basically the thing, and it's like a fight in between these animals. Basically, that's what I mean. But the thing which I wanted to talk about regarding Pokemon is the transformation of this little thing to this another thing, to this another big thing, this big scary thing. Okay, so that is basically what happens in Pokemon. And similarly, this thing is also happening over here in schizophrenia. So what's happening is, at first, okay, so at first what you have is, if you have the symptoms for less than 1 month, okay, if you have the symptoms for less than 1 month, so let's say you have the symptoms from 0 to 1. Okay, we are calling it BPD. Okay, patient goes to hospital, gets a dose of lorazepam, okay, maybe a small dose of haloperidol and everything, and he or she is okay. Now they're back. Okay, 0 to 1 month. So that's okay. But if this continues for 1 month to 6 month, okay, then this Pokemon over here, this BPD Pokemon is transforming, okay, and it's transforming to schizophreniforming or transforming schizophreniform. Okay, so as I like to think, schizophreniform disorder, meaning it's schizophrenia as of not yet, but eventually it's transforming into schizophrenia. And then if it continues for full blown more than 6 months, okay, if it continues for a full blown disease for 6 months or more, then we are calling this schizophrenia. Okay, so the symptoms are the same. BPD, you have to have one or more. Schizophreniform, you have to have two or more. Schizophrenia, you have to have two or more. Sorry, two or more. Okay, or 1 to 3. 1 to 3 meaning delusions, hallucinations, and disorganized speech and catatonic behavior. Have you guys understood the timeline? Have you guys understood the timeline? Okay. Okay. So next time, what are the two things that you have to look out for in your question in order to make the right diagnosis? You have to look out for, first of all, you have to look out for delusion, hallucination, disorganized speech, disorganized behavior, and negative symptoms. Out of this, how about you write them down in your rough page when you are solving the questions, and then you underline what symptoms the patients have. Let's say the patients have D for delusion, hallucination. So they already have two symptoms. So you are diagnosing this as either BPD, schizophreniform, or schizophrenia. The next thing you have to look out for is the timing. That is 0 to 1, or 1 to 6, or more than 6. If it's 0 to 1, BPD, 1 to 6, schizophreniform, more than 6, schizophrenia. Okay, are we clear on this? Is this okay? Okay, it seems very easy right now, doesn't it? After you break down the whole thing. So right now, not only are you understanding one disease, you are actually understanding three diseases. Okay, so that's what it is. Okay, next one is if I have to ask you about um, if I have to ask you about the neurotransmitter damage in a psychotic patient, what is the number one neurotransmitter that is damaged or decreased or abnormal? Dopamine. Very good. Okay, dopamine. And we also talked about the pathways. Do you guys remember we talked about the mesolimbic, mesocortical, and we talked about how one of those pathway was involved for the positive symptoms? And yes, the answer for is mesolimbic. Mesolimbic Mesolimbic was associated with the positive symptoms. Okay, good. Next one is what would happen is if you have a patient who has schizophrenia, what they will have is they will have altered dopamine activity, okay, and increased serotonin activity. Okay, increased serotonin is associated with increased positive symptoms and decreased dendritic branching. Okay, these are not high yield. Okay, these are not high yield. We're just going to read through them to see what's up. Lifetime prevalence 1.5% in males, more than females, not high yield. Prevents earlier in male. I mean, it presents earlier in male than in women. Increased risk of suicide. Okay, it's not high yield as of yet. Heavy cannabis use in adolescents, that is, young people who smoke a lot of weed in school, is associated with increased incidence and worsened course. I do not know why I said smoking weed in school. Okay, that's not what happens over here in America. Okay, you cannot smoke weed in school, but that's what basically your high school students, that's what they do. Okay, so heavy cannabis use in adolescent is associated with increased incidence and worsened course of psychotic mood. Still not high yield. Now we are going to the high yield one. Treatment. How do you treat a patient with schizophrenia? First of all, you have to prescribe antipsychotics. Okay, risperidone. Okay, first of all, what is our number one fear for a schizophrenic patient? What is the number one fear for a schizophrenic patient? If the patient has schizophrenia, what's the problem? The patient is having delusions, hallucinations, he's seeing things. He's not bothering you. Okay, he's not bothering the physician. What's the problem? Yes, the problem is suicide. Okay, the problem is suicide and self-harm. Yes, so the patient could be extremely suicidal, and he wouldn't even know that he or she is being suicidal. They would be so delusional. They would think that basically if they jump they can fly, so they would eventually commit suicide, knowingly or unknowingly. So the diagnosis has to be taken into consideration and into extreme concern. So atypical antipsychotics are your number one. Okay. Okay, and the negative symptoms, they often persist after treatment. Okay, so the negative symptoms are basically the flat affect, apathy, and hedonia, and these are some of the symptoms which can persist for a long period of time. Okay, are we clear on schizophrenia? Okay, I will use red pen, obviously. Okay, okay, are we clear on schizophrenia, brief psychotic disorder, schizophreniform disorder? Okay, okay, next one I want to talk about is, okay, first of all, let me use the red. Okay, Dr. Nadeem. Okay, here we go. So red, there you go. Okay. The next one is schizoaffective disorder. So what is schizoaffective disorder? Now, the schizoaffective disorder will share symptoms with both schizophrenia and mood disorders. Okay. So basically you have, basically what's going on over here is, if I have to talk about, okay, if I have to talk about schizoaffective disorder, okay, so psychotic disorders can be, okay, mood disorders. Okay, mood disorders. Mood disorders have diseases, for example, major depressive disorders or bipolar disorders, or they could also be the schizophrenic disorders. Okay, the schizophrenic disorder, meaning the disorders of delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms. These are the schizophrenic sign symptoms. Okay, and the schizoaffective disorder can have sign symptoms from both of these two together. Okay, and in order for us to differentiate from a mood disorder, the patients must have two or more, okay, the patients must have more than 2 weeks of psychotic symptoms, meaning the schizophrenic symptoms. Okay, the patient should have more than 2 weeks of schizophrenic symptoms without any um, without any mood disorder symptoms. Okay, so what's going on over here? First of all, let me break this down once again. First of all, in psychiatric illness, okay, the patients can have mood disorders such as major depressive disorders, or the patients can also have another mood disorder such as bipolar disorder. These are psychiatric illness where they affect the patient's mood. Okay, okay, happy or sad, basically that's what it is. Okay, and then the next ones are your schizophrenic disorder. That is your disorder, that is delusions, hallucination, disorganized speech, disorganized behavior, and negative symptoms. So these are the one for the schizophrenia. Now, in order for you to diagnose a patient with schizoaffective, not schizophreniform, be very careful about schizophreniform and schizoaffective disorder. The patient should have sign symptoms of both of these things, okay, both of these two problems, and these sign symptoms should last for at least more than 2 weeks. So what would happen is, in those 2 weeks, more than 2 weeks that they would last, they should have more of the sign symptoms of delusions, hallucinations, and disorganized speech, disorganized behavior. And in those 2 weeks, they should not have sign symptoms of major depressive disorders or bipolar disorders. What are the sign symptoms of major depressive disorders and bipolar disorders? For example, you can have for example, you can have symptoms of distractibility, impulsivity, grandiosity, okay, flight of ideas, agitation. So, and then depressed mood, guilt, suicidal ideation. These are all sign symptoms of mood disorders. So, if the patient has 2 weeks or more of only these things, of only these symptoms, without the symptoms of major depressive or bipolar disorder, only then you can tell that this patient is schizoaffective. Schizoaffective. Are we clear? Are we clear about schizoaffective disorder? Okay. So, schizoaffective disorder, if the patients have to have symptoms for 2 weeks or more, 2 weeks or more. What type of symptoms should the patients have? Mood disorders or schizophrenic disorders in order to be diagnosed as schizoaffective. Mood disorders. They not mood disorders. They should not have mood disorders. Schizoaffective. Schizoaffective. Okay, once again. Okay, this is a bit confusing. If you can understand this, then you have understood a lot. Okay, that's what it is. First of all, schizoaffective disorder. I'm going to start from over here again. Schizoaffective disorder. Patients will have sign symptoms of. Let's say you have a young boy. Okay, let's say you have a young boy who is very depressed all the time. So he has a mood problem. At the same time, the young boy has a problem of hallucinating. Okay, so he also has a schizophrenic problem. Okay, and what happens is all of a sudden, for the next 2 weeks, the young boy is happy. So he is not sad anymore. So that is gone. He only sees things. So he's only hallucinating. So more than 2 weeks of only the schizophrenic sign symptoms. Okay, now after 2 weeks, what happens is the mood problems come back again. After 2 weeks, the mood problem comes back again. Now the boy is sad and hallucinating once again, but for that period of 2 weeks he did not have any mood problems. This this child over here is schizoaffective. Okay, this child over here is schizoaffective. Yes. Okay. Okay, are we clear? Is everyone clear about schizoaffective disorder? Okay. Do not worry, when we receive questions regarding schizoaffective disorder, everything will seem a lot clearer. Okay. Everything will seem a lot clearer. Once again, schizoaffective disorder, patients will have mood symptoms and schizophrenic symptoms. You will suspect schizoaffective disorder. Then the patient will have more than 2 weeks of the patients will have 2 weeks or more of the psychotic symptoms without the mood symptoms. Mood symptoms will disappear. If the mood symptoms disappear all of a sudden for 2 weeks or more, then the patient can be diagnosed as schizoaffective. Okay. Okay. Are we clear on schizoaffective? Okay, let me ask a small group of questions to see how far we are in terms of our understanding of psychiatric illness. First of all, you have a patient who comes to you with delusions and hallucinations because he's extremely stressed out and it has not been a long time. What is your diagnosis? What is your diagnosis? BPD. Very good. Next one is the patient's sign symptoms does not resolve after the stress has been taken out. The patient still has delusions, hallucinations. Now the patient has disorganized speech and disorganized thought, and it's 4 months into the disease. What is the problem? SPD, schizophreniform, means the Pokemon over here is transforming. Okay. Now this Pokemon has stayed for more than 6 months already. Okay, and now the final form of this disorganized speech hallucinations for 6 months or more is schizophrenia. Okay, very good. Next one is you have another patient who comes and tells you that I have times when I feel extremely down. I'm really upset. I keep on crying for no reason. And at times I start hallucinating. But for the last 2 weeks, I have been only hallucinating and I have not had any problem with my depression. So that is schizoaffective disorder. Okay, very good. Very good. That is schizoaffective disorder. Okay, next one. Next one is, next one is, next one is, I want to talk about this another thing that is DD. DD is basically delusional disorder. It's delusional disorder. What is delusional disorder? Delusional disorder is, do you guys remember the types of delusions that we talked about yesterday? Delusions of grandeur, jealousy, somatic, mixed. Yes? Okay, good. If you have a patient who has one or more of those delusions, one or more of those delusions for more than 1 month without any without any mood or psychiatric symptoms, then this patient is called is diagnosed to have a delusional disorder. So basically what's happening is if you have a patient who has, let's say, delusions of grandeur, meaning that he is going and telling the world that he is the president of the United States. He has been recently elected and Joe Biden has been kicked out of the White House. Okay, and now he is the president. And he has been saying this for the last almost 1 month. Okay, and he firmly believes it. But when you try to assess that this patient, that whether he is depressed or not depressed, you see that he is not depressed. And when you ask him that do you hallucinate, or do you feel the need to talk to people too much, or do you feel the need, or do you get really sad and upset, and he tells you, no, I firmly believe that I am the president of the United States and Joe Biden has been kicked out of the White House, and he has been saying this for more than 1 month. This patient of yours is diagnosed to have a delusional disorder. So more than one delusions for more than 1 month without any manic or without any mood or psychotic sign symptoms. Are we clear? Are we clear? Yes, Trump. Yes. So this friend of ours is our ex-president, Donald Trump. Okay, that's what it is. Okay. Okay, good. Next one. Okay, next one. Next one is okay. I want to talk about another type of disorder. Okay, I want to talk about another type of disorder. First of all, I want you to read this out. Okay, this is a very interesting type of problem. Schizotypal personality. What is schizotypal personality? Okay, schizotypal personality is basically a class A personality disorder that also falls on the schizophrenia spectrum. May include brief psychotic episodes, that is delusions, that are less frequent and severe than in schizophrenia. Okay, okay. How many of you guys have watched Friends over here? Friends. I'm pretty sure a lot of you guys have watched. Anyone over here who has never watched Friends? Anyone over here who has, okay, if you have never watched Friends, please watch Friends. Okay, please, that is one thing which you have to watch. Okay, good. So the thing is, for all the students who have watched Friends, do you guys remember Phoebe Buffay from Friends? Okay, schizotypal. Okay, so okay, breaking news. Phoebe Buffay is your schizotypal personality. Okay, schizotypal personality, meaning personality where, okay, a personality where the person is bizarre. Okay, meaning that the person is bizarre. They have brief psychotic episodes. Whereas, for example, if Phoebe Buffay in Friends, she used to have certain beliefs in certain things that made no sense to anyone. Okay, so sort of delusional. They were a bit delusional. And another thing is they were also less frequent. And what happens is if this keeps on continuing for a long period of time, this puts this type of people with disorder to develop full-blown schizophrenia. Okay, to develop full-blown schizophrenia. Okay, let me show you a person how he looks like. Okay, on schizotypal. So basically, these are your people who wears, okay, these are your people, schizotypal people. Okay, okay, so these are your people who wears bizarre clothes. So let's say you have a patient who comes to you. The patient comes to you and the patient is wearing something which is completely bizarre. Okay, it's not in the name of fashion. So let's say out of nowhere this patient has a red face, okay, because he has a red makeup on, and then he's wearing a yellow shirt, and with that he is wearing this weird pant which does not go in any way with that. Along with this he has his sleeves made up of purple color. Okay, so this multicolored patient's over here. Okay, and this patient, okay, who has certain beliefs in certain things. Okay, he is a bit of a he is delusional. Okay, he has a delusional problem. And these type of people are your schizotypal people, so meaning the bizarre people. Okay, multicolored people. Okay, so that's what it is. So have you guys understood schizotypal? Okay, they believe everything. I mean, they're very delusional. Okay, not really. If you have not really understood schizotypal people, first of all, schizotypal personality disorder. Schizotypal personality disorder meaning that people with these type of personalities, they have the need to wear clothes which does not go in any way, multicolored clothes. They talk in a different way. Okay, they believe in a certain way. Okay, and then they tell you that if they say something, then that will happen. Okay, completely delusional. And these type of people are very normal. There's nothing wrong with them. This is just a personality. This is just a personality classification. But the only thing to look out for these patients are that these patients are at risk of developing full blown schizophrenia if this keeps on continuing for a long period of time. Okay, they are not attention seeking. They are not attention seeking. Attention seeking people are known as histrionic personalities. Histrionic personality disorder. That is another type of personality disorder. Okay, so attention seeking should be histrionic or narcissistic, more of the histrionic category. Okay, so it's not attention seeking. It's people literally who lives in their own world and believes everything that they think is right is right. Okay, that's what it is. Okay. Okay. Are we done with schizotypal? Have we understood schizotypal personality finally? Okay. Okay, good. Good. Next one that I want to talk about are the next one that I want to talk to you about is you have this have you guys do you guys have any people in your family member that he loves to stay introverted whenever there's a family gathering? He or she likes to stay in their room, does not like to come outside of the room, basically stays in the room, plays games. And it's not like he or she play games with everyone else. They like playing games by themselves. There's absolutely nothing wrong with them. They're very brilliant. Okay, they have a job. They do not have an active they do not have the need to have an active love life or be in any sort of relationships with anyone. Okay. Do you guys know these type of people? I have one or two in my own family. Okay, they are very happy with themselves. They do not need anyone else. Okay, they do not need anyone else. And it's not like they're depressed. They just choose not to be with anyone else. And these type of people are known as people with schizoid personality disorder. Schizoid. Okay, these type of people are known as schizoid personality. Schizoid. Okay, that is known as schizoid personality disorder. Okay, can I get 1 second, please? Okay. Okay. All right. Okay. My apologies. Okay. So are we? So are we done understanding the schizoid personality? Are we done understanding the schizoid personality? Schizoid personality. So there are how many things did we learn right now in a span of half an hour to 40 minutes? We learned about BPD. We learned about schizophreniform disorder. We learned about schizophrenia. We learned about schizoaffective disorder. We learned about schizotypal personality disorder. And now we learned about schizoid personality disorder. Okay. Before I move any forward, I would need you guys. Okay. What I would need is I would need you guys to tell me what this patient is. Okay, so if you guys can please unmute yourselves and answer me the questions, I would be really grateful. So first of all, you have this patient over here. Okay, so this patient, first of all, this patient, he has a problem of thinking that he is the best person in the world. Okay, there's no one stronger than him, and he is having these things, these thoughts, along with the fact that he is also hallucinating. He is seeing things that's not there, and that's been happening for less than 1 month. What is your diagnosis?
Delusion.
Psychotic disorder.
Brief psychotic disorder.
Brief
Delusional.
psychotic disorder.
Psychotic
Deep
disorder.
psychotic disorder. It's not a delusional disorder because he also has he
Hallucination.
also has hallucination. Very good. If this
Okay.
problem lasts from 1 to 6 months, what is the diagnosis?
Schizophrenia.
Schizophreniform
Schizophrenia.
disorder.
Disorder.
Schizophreniform.
Very
Schizophreniform.
Schizophrenia.
Schizophrenic form, yeah.
more than 6 months.
Schizophrenia.
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 Schizophrenia. Good. Okay. Now this guy over here. Okay. This is another guy over here. This guy, his problem is that he is sad all the time, and he also sees things that is not there. But lately, for the last 2 weeks, he is only having hallucinations. So his sadness is gone. He's not sad anymore.
Schizoaffective.
Schizoaffective
Schizoaffective
disorder.
disorder.
Schizoactive.
Schizoaffective
Affective
disorder.
disorder.
Very good. Next one. Next one is you have this guy. He believes he believes that doctors are not important. You can treat patients with rocks. Okay, you can treat patients with rocks, and he wears things which are uncommon, which does not go with each other at all. Okay, and he always does this because he wants to stand out. Okay, I
Delusional.
firmly believe.
Schizotype.
Schizotype
Schizotype
personality.
personality.
Very good. Schizotypal personality disorder. Next one is my little cousin who stays home during family gatherings. Okay, plays games, does not feel the need to come out and talk to anyone, and he has been
Schizoid.
for the last many years of his life.
Zoid.
Schizoid.
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 Okay, schizoid. Okay. Okay, have we missed out on anything? We have missed out on delusional disorder.
Delusion.
Delusional
Delusion
disorder.
disorder.
Delusional disorder is basically delusion, meaning one or more of the delusional disorders. Okay, for more than 1 month. Okay, that's your delusional disorder. That's it. Okay, having said that, thank you so much for your active participation. That's what it is. Okay, so have you guys understood all the high yields before we move on to the next group of disorders? Okay, okay. So before we move on to the next group of disorders, our next group of disorder is mood disorders. Okay, our next group of disorders are mood disorders. So first of all, let's read the text. Let's see what mood disorders are. They're characterized by abnormal range of moods or internal emotional states and loss of control over them. Okay, so basically you do not have control over your moods. The severity of the moods can cause distress and impairment in social and occupational functioning, includes major depressive disorder, okay, then bipolar disorder, then dysthymic and cyclothymic, dysthymic and cyclothymic disorders. The episodic superimposed psychotic features may be present. Okay, do you have to memorize and keep in mind about all this thing about mood disorders? Yes or no? Do you have to memorize or keep in mind about all this text about mood disorders and on first date? Yes or no? Okay. Okay, so that's what it is. Okay, so so we do not have to remember about all the text over here in mood disorders. Okay, we just have to read through first aid and see if we understand psychiatry. That's all we have to do. Next one is manic disorders. Okay, so we want to talk about manic disorders. So what is manic disorder? First of all, in order for you to diagnose a patient with mania, okay, the patient has to have a certain amount of, okay, the patient has to have a certain amount of symptoms. What are those symptoms? The symptoms can be said as dig fast. Okay, so these are the sign symptoms for mania. We are done studying the sign symptoms of psychosis, which are delusion, hallucination, disorganized speech, disorganized behavior, and negative symptoms. Now we are talking about mania. Mania is basically, it could be diagnosed by these following sign symptoms. So first of all, number one, D for distractibility. Okay, distractible. So what is distractibility? Distractibility basically means that, let's say we are talking about something, and then out of nowhere you change the topic, and then you start talking about something else. You are very distracted, meaning that you are not focused on one single topic. Okay, so that is distractibility. Number one, distractibility. Number one is distractibility. Number two is impulsivity. Impulsivity. What is impulsivity? Impulsivity is basically you act on any thought or idea that comes in your head. Okay, let's say you think all of a sudden that you want to jump off the bridge, and then you jump off the bridge. That is known as impulsivity. Okay, so you're very impulsive. Next one is grandiosity. Okay, grandiosity. Okay, grandiosity, meaning that you are the best in the world. There's no one in the world who's better than you. Okay, and you firmly believe that, and there is nothing in the world that you cannot do. There is nothing in the world that you cannot do. You can sing, you can dance, you can give lectures, everything. Okay, so that's what it is. Next one is flight of ideas. Next one is flight of ideas. Okay, if someone asks you for a piece of advice or for an idea, okay, if someone asks you for a piece of advice or for an idea, you have all the ideas in the world to give it to that person, that this is how you can do this job, this is how you can do that job. Okay, so he has a lot of ideas in his head. Okay, number five is agitation. What is agitation? It's easy to understand that you easily get pissed off and angry at almost anything and everything that is sensitive to you. Okay, so let's say you don't like something. Let's say you don't like having ketchup, right? And if someone asks you, okay, do you want some ketchup with your do you want some ketchup with your French fries, and then you just get mad at them, and you keep on shouting at them, and just tell them that, like, I can't believe you forgot that I don't like ketchup and stuff. You just make silly things big. You just make like a big thing out of a small thing, and you just get extremely angry, which is out of proportion to the context. So that is agitation. So that's what it is. Okay, next one is decreased sleep. Okay, you feel the need to sleep less. Okay, you do not need sleep at all. You feel the need to sleep less because you're so hyper that you have this flight of ideas that you want to go to. Next one is talking or pressured speech, meaning that you feel the need to talk to anyone and everyone as much as you can. So DIGFAST, that's what it is. Okay, so that's what it is. Have you guys understood all the 7 sign symptoms? Have you guys understood all the 7 sign symptoms? Okay. Okay, good. Okay. Okay, good. Now, if you have to diagnose a patient with mania, okay, if you have to diagnose a patient with mania, what you would need is, okay, what you would need is, okay, let me use a different color. Three or more of these sign symptoms for 3 or more of these sign symptoms for more than 1 week. Okay, so dig fast. Dig fast is distractibility, impulsivity, grandiosity. Then you have flight of ideas, agitation, decreased sleep, and talkativeness. If you have three of these sign symptoms, three or more of these sign symptoms for more than 1 week, for 1 week or more, then you can be diagnosed as a patient of mania or manic episode. You're having a manic episode. Are we clear on this? Are we clear? Okay. Please explain bipolar. Of course, we will explain bipolar. We have not come to bipolar yet. Okay, please. Okay, we will explain bipolar. There's nothing to be worried about. Bipolar falls and manic disorders. Okay, so just have a little bit patience, and we will come to bipolar disease in no time. Okay, have you understood the manic episodes? Impulsivity, confusion between. Bipolar is a type of manic disorder. It's not anything different from a manic disorder. Okay. Bipolar is a type of manic disorder. Okay. In order for you to diagnose bipolar disease, you have to understand what a manic episode looks like. This is how a manic episode looks like. In order for you to diagnose a patient with a manic episode, the patient should have three or more of these sign symptoms for 1 week or more. Okay, for 1 week or more. Are we clear on this? Are we clear on this? Okay, next one. Okay, next one I want to talk about is hypomanic disorder. So what is hypomanic disorder? Hypomanic disorder is more or less similar to a manic disorder, except the mood disturbance is not severe enough to cause marked impairment in social and occupational functioning. Okay, and the abnormality is usually increased activity or energy, which is usually present, but no, there are no psychotic features, and it lasts for 4 or more consecutive days. It lasts for 4 or more consecutive days. So if you have a patient who is having a manic episode, let's say you have a patient who is distracted, impulsive, patient has grandiosity, flight of ideas, do you think that this patient can go to the office and work properly? Yes or no? Do you think that this type of patients can go to the office and work properly? No, they can't, because they'll get into fights, they'll get fired, that there will be a lot of problems. But what if I tell you that you have another group of patients, okay, who has these similar problems, that the patient is distracted, the patient is impulsive, but these sign symptoms are not so severe that the patient cannot go and work in the office. Is it possible? Yes or no? Is it possible? Yes or no? That you can have sign symptoms of manic episodes, but they are not so severe that it will cause occupational um, in functioning. Okay. Are these possible? Yes, they are possible. So these patients who have sign symptoms of mania, but they are not causing problems in their office or their occupational functioning, these patients are known to have hypomanic episodes. These patients are known to have hypomanic episodes. And how long should your patient with hypomania last? These problems should last. They should last for 4 or more days. 4 or more days in order to be diagnosed as hypomania. Hypomania. Are we clear on mania and hypomania? Are we clear on mania and hypomania? Is there anyone over here who can explain to me what mania and hypomania is before we move on? Is there anyone who can explain to me what mania and hypomania is? Okay. Okay. First of all, what I would do is, if I ask you guys about mania and hypomania, I will ask you about dig fast. Okay. So I'm going to give you exactly 30 seconds. Okay. Please try to review and understand dig fast. Okay. By dig fast, distractive, impulsive, grandiose, flight of ideas, agitation, decreased sleep, and talkativeness. Make sure you guys can produce this information in 30 seconds. So please read it, and please let me know who is interested in doing the active participation. Okay? Okay, so 30 seconds. Okay, is anyone ready? Can anyone tell me what they mean by dig fast and mania and hypomania? Okay, good. So let's see, let's have Dr. Iman over here. Would you be kind enough to please tell us what do you mean by the mnemonic dig fast? Would you be kind enough to tell us what do you mean by the mnemonic that is dig fast?
Yeah, it big fast, destructibility,
Okay.
impulsivity, and
Mhm.
granulosity.
Mhm.
Fast, F for flight of idea,
Okay.
A for agitation, S
Okay.
for decreased sleep,
Okay.
and fast, T for talkative.
Okay, talkativeness. If I tell you you have to diagnose a patient with mania, how many of these symptoms should be present and for how long?
It should be three or more for 1 week or more.
1 week. Very good. Is a patient who is undergoing a manic episode, can they work in office and have a normal life?
No, because
Okay. How about another patient who has sign symptoms of dig fast, but they are not so severe that they will cause occupational impairment? What is this diagnosis?
hypomania,
Mhm. How long should they last?
it 4 days
Four
and
or more?
less severe, not affect activity.
Right. Very good. Thank you. Thank you so much, Dr. Iman, for performing. That's exactly what it is. Okay. Have you guys all heard and understood the conversation that we just had, me and Dr. Iman, on the discussions of mania and hypomania? It should be very clear by now what mania is, what hypomania is. Okay. Okay, good. Next one. Now it's time to go to Dr. Ahmed, Dr. Omar Ahmed's question, and okay, and now we will discuss about bipolar disease. Okay, first of all, if I want to talk about bipolar disease, how many types of bipolar diseases are there? How many types of bipolar disease are there? Bipolar disease. What are the types of bipolar disease? Okay, Dr. Ibrahim, did you just look at the book and tell me the answer? Okay, so there are two types of bipolar disease. Okay, so that's what it is. The another thing is cyclothymic disorder is not bipolar disorder. Bipolar disorder is bipolar 1, okay, and bipolar 2. Okay, so that is bipolar disorder. Now, in bipolar 1, in order for you to diagnose a patient with bipolar 1, okay, in order for you to diagnose a patient with bipolar 1, what you need is you need one or more. Okay, 1 second. Let me mess this up. One or more of the manic episode which we just talked about, which has dig fast for 3 or more sign symptoms for more than 1 week. If you have one of those episodes, okay, with or without, with or without hypomania or depression or depressive disorder, then the patient can be called as bipolar type 1. Okay, let me break this down again. What is bipolar type 1? In order for you to diagnose a patient with bipolar type 1, number one thing is they should have a manic episode. Okay, that is the episode we just talked about. And they should have more than one or more than one. And that manic episode could either be with hypomania and depression or without hypomania and depression. Are we clear on bipolar type 1? Are we clear? Basically, bipolar type 1 is your patient who has more than one manic episode, very clearly. Have you understood the manic episode, Dr. Karbasi? Have you understood what the manic episode is? Okay. If a patient has a manic episode for 1 or more than 1 week, okay, then this patient is bipolar type 1. Are we clear now? Are we clear now, Dr. Karbasi? Okay, hypomania. Hypomania. Okay, okay. Basically, what's happening over here that in bipolar type 1, what happens is you can have a patient with manic episode at the same time. Mania and hypomania can be present in one patient at the same time. And how can that happen? Basically, what would happen is after 1 week of the manic episode, if the symptoms get lowered, if the symptoms get less severe and the patient can finally have the confidence to start working, then the patient also has hypomania. So that is mania and hypomania being together. Okay, mania and hypomania being together, so they can coincide together at the same time. But what I'm talking about is, in order for you to diagnose a patient with bipolar disease, your number one criteria should be more than one manic episode. With that, the patient can have hypomania or cannot have hypomania. That's not the problem. Or the patient can have depression or not have depression or a depressive episode. That is another criteria. So that's what it is. So but the number one thing is the patient has to have week, one or more manic episode. Are we clear now on bipolar type 1? Does anyone have any confusion? Please, now is the time to let me know. This mania can become hypomania after start treatment. No, mania cannot become hypomania. Mania will completely resolve after treatment. Okay. Okay. Can it be hypomania and depression together? Yes, it can be hypomania and depression together. Time frame. Yeah, the time frame is the same for manic episode. So what is the time frame for manic episode? What is the time frame for manic episode? Manic episode, 1 week. So that's the exact time frame for bipolar type 1 too. 1 week. So one or more manic episodes. If there are two manic episodes, how long is the duration? If there are two manic episodes, how long is the duration? Two manic episodes. How long does it take to have two manic episodes? If one episode is 1 week, then two episodes are 2 weeks. Okay, so that's what it is. Okay, so it all depends on the manic episode. How many of them is the patient having? Is if the patient has one manic episode, it's 1 week. If it's two, then it's 2 weeks. Okay, so that's what it is. But the thing is, the patient has to have at least one manic episode, and that could be with or without hypomania and depression, and that is bipolar type 1. Are we clear? Okay, clear. Very good. Next one, bipolar type 2. Very easy to diagnose bipolar type 2. What is bipolar type 2? Bipolar type 2 patients will have hypomania, meaning that they have sign symptoms of dick fast, but they are not so severe that they will cause occupational impairment. But bipolar type 2 patients will also have depressive sign symptoms or depressive episodes where they will be extremely down. Okay, we will talk about the sign symptoms of depression very soon, but you guys know what depression is. So hypomania and depression, and they will coincide with one another without, now this is the thing, without mania or manic episodes. So these patients will not have manic episodes. They will only have hypomania and depression. Okay. Are we clear? Are we clear on bipolar type 2? Okay. Next question. Would you please explain why bipolar is one characteristic of mood disorder? Would you explain why bipolar is a one characteristic of mood disorder? Characteristic of mood disorder. Okay. Is your question, what is your question? Is your question mood disorder, meaning that why is bipolar a subtype of mood disorder? Is that your question? What is your question, please? Dr. Ahmed? Okay, would you please rephrase your question? I apologize for not being able to understand your question. Okay. Okay, having said that, have you guys understood bipolar type 1 and type 2? Bipolar type 1 and bipolar type 2 before we move forward? Okay. Once again, what is bipolar type 1? Bipolar type 1 is your patient who has the one or more manic episodes with or without hypomania and depression. Bipolar type 2 is your patient who has hypomania and depression without manic episode. That is bipolar type 1 and bipolar type 2. If you guys understand manic episodes, then it should not be hard for you to understand what bipolar and type 1 and type 2 is. Are we clear? Next question, does that mean if no hypomanic or depressive symptoms seen in bipolar type 1, is it automatically a manic episode? Okay. In order for a patient to be diagnosed as bipolar type 1, he should have one or more manic episodes with or without hypomania or depression. If the patient has a manic episode without hypomania and depression, then instantly it's bipolar type 1. Are we clear? Are we clear right now? Okay, does anyone have any confusion before we move forward? Because if you do, now is the time to tell me, because it will only keep on getting confusing if you don't not address the problem. If patient have mania for 1 month, is this bipolar? Yes, that is bipolar. Without, if it has no hypomania or depression, then yeah, it's bipolar type 1. Okay, hope that answers your question, Dr. Iman. Next one, term manic episode. Manic episode is basically that episode which lasts for 1 or more weeks of 3 or more sign symptoms of dick fast. That is manic episode. Any other question? Any other question, please? Yes or no, basically, because I need to move forward. Okay. Okay. So moving forward. Okay. So moving right now, moving forward, what we need to do is how do we treat a patient with bipolar disorder? First of all, if you have to treat a patient for bipolar type 2, antidepressants can destabilize the mood. So you can use antidepressants because bipolar type 2 patients have depression and hypomania, right? The suicide risk is high. So treatments are usually, what is the number one treatment for bipolar is mood stabilizers. First of all, our number one mood stabilizer is lithium. Okay, lithium, then valproic acid, carbamazepine, lamotrigine. Okay, do you guys remember these actions for valproic acid? Valproic acid. Do you guys remember the mnemonic that we used? Valblock acid. Very good. Do you guys remember carbamazepine? Carbamazepine. Carbamazepine. Okay, good. Do you guys remember our lame drug? Lamotrigine. Okay, the lame drug. Okay, good. That's what it is. Good, very good. So that's what it is. So these are the drugs that you can use to treat. These are the drugs that you can use to treat bipolar type 2. But the number one drug that you need to treat bipolar is lithium. Okay, so lithium. If we use lithium, can you guys tell me of an endocrinological problem which the patient are prone to have? We talked about in URL, SIAD, and do patients with lithium get nephrogenic diabetes insipidus? Yes or no? Very good. Okay, nephrogenic diabetes insipidus. Okay, good. Next one I want to talk about is cyclothymic disorder. Next one I want to talk about is cyclothymic disorder. What is cyclothymic disorder? This is a milder form of bipolar disorder which will fluctuate between depressive and hypomanic episodes. So what do you mean by fluctuating? Fluctuating meaning that the signs symptoms will go to either depression or they can go to hypomania. And the thing is, the time frame for cyclothymic disorder is that they must last for 2 or more years. They must last for 2 or more years with symptoms present at least half of the time. So they will not always be present. So let's say the symptoms are present out of the span of 2 years, the symptoms are present for 6 months and then they go away. And then the symptoms come again then the symptoms come back again in this span of 2 years with any remission, meaning that you get better from the disease, lasting for with any remission lasting for 2 months or less. Okay, so what will happen over here? Okay, so what will happen over here, that in order for you to diagnose a cyclothymic disorder, the patient has to have hypomania and the patient has to have depression, depressive episodes, and these symptoms will last for 2 years or more. Okay, so the time frame that you need to diagnose the patient is for cyclothymia is 2 years or more, And out of those 2 years, there will be times where the patient will be okay, meaning that the patient will be normal, and then the patient can again have these episodes of cyclothymia. But the thing is, it cannot be solved or with any remission, meaning that it has to be back between 2 months. Am I clear? I mean, the patient cannot be free of symptoms for less than 2 months. The symptoms have to come back in 2 months or less. Okay, the patient cannot be symptom free for more than 2 months. Are we clear? Resolved, yes. Okay. Again, what is cyclothymic disorder? Cyclothymic disorder is the patient will have what type of signs symptoms? Hypomania or mania? Fast answers, please. Fast answers, please. Hypomania. Along with hypomania, what other sign symptoms will this patient have? Depression. Okay. And if I tell you that these sign symptoms are present for the last 2 years, but they have not always been present, they get absent at times, but this absence is not more than 2 months. Okay. This absence is not more than 2 months. Well, what is your diagnosis? Cyclothymia. Cyclothymia. Now, let me tell you a story about this friend of mine. Okay, so I have this one friend. Okay, I have this one friend. His problem is okay. His problem is he was okay. He was doing very well in his life. Okay, but all of a sudden, for the last almost 2 weeks, this friend of mine, he has become extremely impulsive. Okay, he has not slept for the last 3 weeks. His mother complained that he has not slept for the last 3 weeks because he keeps on thinking that the government is out there to get him. Okay, so he is making a gun in his basement to fight off the government, and he has not slept for the last 1 week, and this has been happening for quite a long time. Okay, and what do you think the diagnosis of my friend is? What do you think the diagnosis of my friend is? Anyone? My friend's mother, she complained that my friend stays in the basement. Okay. My friend stays in the basement. He believes that the government is out there to get him. Okay. He has not slept for the last 3 weeks. Okay. He has plans. He feels like he feels like he feels the need to talk to people extremely. Okay. And then and then he has an extreme flight of ideas. Okay, he has an extreme flight of ideas which he cannot get rid of, so he is also writing a book. Yes, this is a manic episode. This is a manic episode. Thank you. Now the thing is, if this friend of mine has more than one manic episode, which he has, what is his diagnosis? Bipolar type 1. Very good. Another one, I have this another friend, okay, who also thinks that the government is out there to get him. Okay, but this has not caused him to lose out on his job. But the thing is, every time he comes back home, he thinks about how the government is out there to get him, and he is very, very depressed about it. Okay, he is very, very sad about it. So this is hypomania and depression together. Okay, and the diagnosis of my friend, what is the diagnosis? Bipolar type 2. Very good. I have this another female friend of mine. Okay, for the last 2 years, she is having sign symptoms of extreme her, extremely distracted. She has been extremely distracted. She cannot focus on her work. Okay, she cannot focus on her work, and then along with this, the patient also has sign symptoms of hypomania. Okay, but at times she completely forgets about this, and this time span of being forgotten for this does not last 2 months. Okay, please, just 1 second, please. Okay. So have you guys understood the story of my three friends? Bipolar, type 1, type 2, and cyclothymic disorder. Okay. Okay. Okay, good. Next one. So are we good to move on to the next group of sign symptoms, that is depressive disorders? Cyclothymic disorders, once again, hypomania and depression lasting for 2 or more years, and symptoms get resolved, but these resolved symptoms do not last for 2 months or more. That is, the symptoms come back in less than 2 months. He's okay throughout those times, but the symptoms come back in two or more in less than 2 months. Okay, in 2 months or less than 2 months, and that is cyclothymic disorder. Okay, dysthymic disorder. We have not come to dysthymic disorder as of yet. We will come to dysthymic disorder very soon. Okay, are we clear? Can we move on to major depressive disorders? Do you guys want to take a short break before we move on to major depressive disorders? Okay, because I feel like there has been a lot. Okay, to take. Okay, 10 minutes. Okay, so let's take that 10 minutes break and let's come back. Okay, are we back from the break? Okay, good. Okay. Is everyone understanding the lecture for today? It's a bit, I know, on the difficult side, but we're trying our best to take our time and break everything down. Um, do we have any confusions regarding the topic we just discussed? Okay. So just please try to keep in mind that although it might be taking us a bit more time to finish, but it's better that we finish it in a proper order. Okay, meaning that we do not rush through the psychiatric problems. If we don't understand psychiatry, then there's no point in reading this over and over again. You will not understand this. Okay, so that's what it is. Okay, so that's that. Okay, so having said that, let's move forward. Okay, the next thing that I want to talk about, the next thing that I want to talk about with you guys is major depressive disorders. Okay, the next thing I want to talk about is major depressive disorders. Okay, so what is major depressive disorders? First of all, in order for a patient to get diagnosed with major depressive disorder, the last thing we studied was dig fast. This time what we are going to study is dig space. Dig space. Okay, what is dig space? Dig space, number one, D for depressed mood, I for loss of interest, G for guilty, okay, S for sleep disturbance, and S again for suicidal ideation, P for psychomotor changes, A for decrease in appetite or increase in appetite, C for decrease in concentration, E for decrease in energy. Okay, so what's happening over here? First of all, you have depressed mood, I for loss of interest, okay, decreased interest, okay. Then we have guilt, then sleep disturbance or suicidal ideations, okay, psychomotor changes, then decreased appetite, decreased concentration, decrease or increase appetite, okay, appetite could increase or appetite could decrease, and decreased energy. Are we clear on the signs symptoms of depression? Okay, okay. So in order for you to get diagnosed with depression, or in order for a patient to get diagnosed with for depression, these episodes, okay, should have, you should have how many? Five or more of these sign symptoms, five or more of these sign symptoms, and they should last for how long? How long should they last for? They should last for 2 or more weeks. Are we clear? Depression, five or more of the sign symptoms, and they should last for 2 or more weeks. Okay, are we clear on this? Are we clear on this? Yes or no? Okay, yes or no? Okay. If I have to diagnose a manic episode, how do you diagnose a manic episode? How do you diagnose a manic episode? Dig fast. And how many of those sign symptoms should be there for how long? Three, four? Three for how long? For how long? For 1 week. Good. And if you have to diagnose a patient with depression, how many of these sign symptoms should the patient have? Five. For how long? For how long? For 2 weeks. Very good. Okay. So one is 3 for 1 week, and the next one is 5 for 2 weeks. Okay. So if you have that, then you have diagnosed depression. And once you have diagnosed depression, I'm pretty sure you guys know the treatments for depression. What is the treatment for depression? First of all, number one is cognitive behavioral therapy. After that, you have SSRIs, SNRIs. So we know that SSRI meaning selective serotonin reuptake inhibitors. Then we have selective serotonin norepinephrine reuptake inhibitors. Okay, and that's that. So that's your SSRI, SNRI. But the thing is, if you give a patient serotonin, okay, do you guys remember that we talked about the fact that the serotonin activity in mania or in psychosis, is it increased or decreased? Is it increased or decreased in psychosis? Increase. Increase, right? So dopamine, and so the thing is, if you give a patient SSRI and the patient is psychotic, will the patient have more psychosis or less psychosis? More psychosis. So is it important for you to exclude psychosis before you administer SSRI? Yes or no? Okay, yes. So that's what it is. Okay. Okay, so that's what it is. So before you start SSRI, you have to exclude psychosis. Okay, so that is one thing which you have to keep in mind. So another thing is, before you start your treatment for depression, you have to rule out manic or hypomanic episode. And please keep that in mind, because this is a very important UL question, that which sign symptoms will you spare in order to before you prescribe your SSRIs, and the sign symptoms of psychosis. Okay, that's what it is. Okay, next one. Next one I want to talk about is MDD with psychotic features. A major depressive disorder with psychotic features. That is your major depressive disorders with hallucinations or delusions. Okay. Um, So, what are MDD with psychotic features? That is, the psychotic features are typically mood congruent, meaning that the patients can have depressive episodes of guilty punishment and all the other sign symptoms, and they can occur only in the context of major depressive disorder. And the treatment is antidepressant with atypical antipsychotic and ECT. ECT stands for electroconvulsive therapy. Okay, basically, now let's say you have a patient who has sign symptoms of depression. Along with that, now the patient is having delusion and hallucinations. Okay, do you guys remember I talked about the fact that major depressive disorder with sign symptoms of hypomania? What is the diagnosis? Major depressive disorder with sign symptoms of hypomania. Bipolar type 2. Very good. Bipolar type 2 is not bipolar type 1. Bipolar type 1 is solely manic episode. There is no hypomania, with or without hypomania, right? But manic episode is number one. But major depressive disorder. So if you have a patient with major depressive disorder and sign symptoms of psychosis, meaning that the patient also has the three sign symptoms, meaning delusions, hallucinations, and disorganized speech. Along with that, the patient also has major depressive disorder. Then this diagnosis is known as major depressive disorder with psychotic features. Are we clear? Are we clear? Okay. So that is your difference between bipolar type 2 and major depressive disorder with psychotic features. Okay. Okay, if we are clear, then we're going to move forward. Okay, if we are clear, then we're going to move forward. The next one is dysthymia. Dysthymia is persistent depressive disorder. Try to realize that cyclothymia and dysthymia, they're completely different things. Dysthymia is milder than MDD, okay, milder than major depressive disorder. And the depressive symptoms are usually two or more of the depressive symptoms, which will last for 2 or more years, okay? And once again, in dysthymia, the symptoms will resolve, but they will not stay resolved for less than 2 months. I mean, they will not stay resolved for more than 2 months. Okay. Once again, what's happening over here? What is this? First of all, can anyone explain to me what cyclothymia is? If they unmute themselves and just tell me what cyclothymia is very fast. What is cyclothymia? Who can tell me what cyclothymia is? Who can tell me what cyclothymia is? Cyclothymia. What is cyclothymia? Who can tell me what cyclothymia is? Anyone? Is there absolutely no one? Oh, we cannot unmute. Okay. Okay, now.
Yeah,
Okay.
it is mild form of mania and depression, hypomania and depression.
And?
It for 2 years
And?
without the gap between episodes. It's supposed to be not than 2 months.
Perfect. Okay, so thank you so much. And thank you so much, Dr. Iman, for saying that. So that is basically cyclothymia. So we have hypomania and depression for 2 years, and there's no remission, where it's lasting less than 2 or less than 2 months. Okay, and the thing is, dysthymia is the same thing. The only difference is in dysthymia, what you have is you have major depressive symptoms. Okay, you have major depressive symptoms which are milder form. Okay, and these milder form of depression, they last for 2 years, and the symptoms, it's not like they do not resolve. The symptoms do resolve, but this symptoms resolving does not last for more than 2 months. Okay, so patient does not stay symptom free for any time more than 2 months or more. Okay, in any time for 2 months or more. That is dysthymia. Are we clear now? Are we clear on dysthymia? Okay, dysthymia. Once again, dysthymia is basically, so we, how about, we have this one patient. So this patient comes to you and tells you that she always feels depressed. She does not feel the need to eat. She always feels the need to sleep. She's always guilty. She has lost interest in her in her daily job. And when you ask her that how long have you been feeling like this, and she tells you that I have been feeling like this for the last 2 years. After that, if you ask her that, okay, does your sign symptoms get resolved? She says yes, it does get resolved. And then if you ask her how long do you stay symptom free of symptoms, and then she tells you that my symptoms are, I stay symptom free for 1 month and then it comes back. Every time I stay symptom free for 1 month or more than 1 month, but it's never 2 months. It's less than 2 months, and then by the end of 2 months it comes back, or very close to 2 months it comes back. This patient of yours, what is the diagnosis? What is the diagnosis? Dysthymic disorder. This patient has been diagnosed with dysthymic disorder. Next one is, if you have another patient who comes to you and tells you that she has that she has sign symptoms of mania, but they are not severe enough to cause occupational impairment. Along with this, the patient also have some symptoms of depressions. Some symptoms of depression, they have been present for 2 years, and the symptoms, they resolve, but they do not stay resolved for more than 2 months. What is your diagnosis? Cyclothymia. Okay, cyclothymic disorder. Okay, are we clear now? Okay, okay. So we have this another type of patients. These patients, what they have is they have only the major depressive disorders, especially at certain time of the year. Like, for example, you have patients who get really depressed when you have rainy days. Okay, you have patients who get really depressed when it's winter. Okay, then you get patients who are having depression on a seasonal variant. Okay, is that a possibility? Yes or no? Is that a possibility? Yes or no? Yes, that's a possibility. And that diagnosis is known as MDD with seasonal pattern. Okay, so the patient will come and complain to you that she only has, or he only has, depression during winter, but during summer he is okay because he goes to the beach and he's having a good time. Okay, so during summer he's okay, but during winter he's very depressed. So this patient of yours has MDD with seasonal pattern depression. Are we clear? Okay. Okay, good. Okay, next one. Next one that I want to talk about is peripartum mood disturbance. So what is peripartum mood disturbance? Okay, this is basically an onset during or shortly after pregnancy or within 4 weeks of delivery. Okay, so this is going to occur within 4 weeks of the delivery, and this occurs if there has been an increased risk with a history of mood disorder. The patient previously had mood disorder. So peripartum is basically the time around the pregnancy in which the patient has mood problems. Now, this disorder can be classified into three three categories. Okay, first of all is maternal blues or postpartum blues. That is very common. It is characterized by depression. Okay, depressed affect, tearfulness, and fatigue, which can last for 2 to 3 days after delivery, but they usually resolve within 2 weeks. Okay, they usually resolve within 2 weeks, and the treatment is very easy. Treatment is reassuring the patient that the patient has nothing but postpartum blues, and the patient has and reassuring the patient is have the treatment, and after that the next half of the treatment is you have to follow up for the patient to see if the symptoms have resolved within the next 2 weeks or not. Okay, have we understood? Have we understood? Have we understood peripartum depression? Okay. Okay. Okay, good. Okay, I think I skipped a little bit. Okay, depression with atypical features. Okay, so before we go on to this, okay, let's go to this one which we just missed. Okay, so thank you for pointing it out. We missed depression with atypical features. Okay, first of all, in depression, do you expect the patient to eat a lot or eat less? Less. Most of the depressive patients, they don't eat a lot. Okay, do you expect them to sleep a lot or sleep less? Sleep a lot. Okay, good. Okay. Now, if I tell you that these patients with depression, all of a sudden, if you tell them that, okay, today we are going to go to Disney World, and they get extremely happy, they get extremely happy. Okay. And is that normal or not normal? Because they were not this happy for a long period of time. And then out of nowhere, you tell them you're going to go to Disney World and they get extremely, extremely happy. Okay. That is not normal. Okay. That basically means that this patient is having mood reactions. Do you know what mood reactions are? Mood reactions are basically, let's say that you are sitting on your sofa. Okay. You are very, very upset, and then all of a sudden you get a call from your friend, and your friend comes and tells you, okay, we're going to go outside, go to the beach, have fun. Okay, your normal reaction should be excitement and happiness. Okay, but you should not be so excited that you should be jumping on your feet, that this is the best thing that ever happened to you. Okay, that is abnormal. Okay, that is mood reaction, mood reactivity. So this thing, especially when the patient previously had depression, if they have certain types of reactions in which they get extremely positive when they hear a good news, or when they eat a lot, that is very atypical, or when they sleep less, especially people, they usually sleep a lot. So the thing is, depression patients, most of them, they don't sleep that much. What would happen is, people with depression, do you remember what we talked about the REM time? What did we talk about the REM time with people in depression? Is it more or less? Okay. Does that mean that they sleep more or they sleep less? They Okay, they sleep less. That's what it is. So what happens is, they try to sleep, they stay in their bed, but their actual sleep time is less. So the thing is, if you have the patient who has mood reactions, the patient eats a lot, the patient sleeps a lot, and these are atypical features of depression, this is known as depression with atypical features. This is known as depression with atypical features. Are we clear? Are we clear on depression with atypical features? No. Okay, to all the students who, yes, very high yield. To all the students who are solving UWorld question, what is the number one drug that you will use to treat atypical depression? Let's see if anyone has the right answer. Anyone solving UWorld made this mistake? I'm pretty sure they have made this mistake. Okay, SSRI was not an option. SSRI was not an option. Okay, what if I tell you that in that whole thing, SSRI was not an option? Okay. 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 Have you guys heard the name of the drug metrazipine? Metrazipine. Metrazipine. Have you guys heard the name of the drug metrazipine? Okay, Dr. Sar, what is metrazipine? What is metrazipine? Fast answers, please. We don't have a lot of time. Does anyone know what that means? Inhibits? Okay, good. A2 inhibitors. Okay, good. Okay. So write down metrazepine beside MAO, okay, for a very, very high yield UWorld question. UWorld has this question where they ask you whether you can use which drug you can use out of all of that. You do not have SSRI, you do not have MAOs. So metrazepine can also be used to treat atypical depression, depression with atypical features. Okay, please write it down in your book. I will explain it. I will explain it when we study psychiatric pharmacology. But for now, just write it down. Metrazepine. Sorry, metrazepine. Okay. Depression with atypical features. Depression with atypical features, meaning that depressive patients should not eat a lot. They usually do not sleep a lot. Okay, and they do not have mood reactions. But if you have a patient who is depressed, has the signs symptoms of depression, the patient is eating a lot, sleeping a lot, and the patient has mood reactivity, meaning that you tell the patient something and then they get extremely positive and happy. That is known as depression with atypical features. Are we clear? How do you diagnose it? You diagnose the patient by the clinical feature, signs, symptoms, and history. Okay. They will tell you in the UWorld question that you have a depression patient, okay, who has extreme changes in mood whenever they hear a good news. Whenever they hear a good news, they have a change in mood and then they get extremely positive. That is your patient with depression with atypical features. Okay. Okay. Good. Okay. So going back to peripartum depression. So the first of all, number one is postpartum blues. Okay. Postpartum blues. Once again, postpartum blues will stay for how long? How long will postpartum blues stays after which it becomes concerning? How long postpartum blues stays after which it becomes concerning? Okay, it's 2 weeks, not 4 weeks. It's 2 weeks. Usually, it should resolve by 2 weeks. Okay. Okay. So what next one is major depressive disorder with peripartum onset, and this is fairly less common. It's also called postpartum depression, and it meets the criteria of major depressive disorder with onset no less than 1 year. So it should start between 1 year. Okay, it should start between 1 year. If for some reason the postpartum blues does not resolve it by itself after 2 weeks and it keeps on continuing and stuff, even from postpartum blues, the patient can have MDD with peripartum onset. And right now, over for this one, only supportive treatment is not enough. Now the patient is in need of CBT and SSRI, meaning cognitive behavioral therapy and SSRIs. Okay, that is MDD with peripartum onset. Are we clear? Next one is postpartum psychosis. What is postpartum psychosis? This is extremely uncommon, only 0.1 to 0.2%. It is characterized by delusions, hallucinations, and disorganized speech and harming, disorganized thoughts of harming the baby or harming oneself. Have you guys ever heard about a case of postpartum psychosis? Anyone? Have you guys heard of postpartum psychosis? To be honest, it's more common than it's more common than they say it is. Okay. How is the voice now? Is the voice better? Is the voice breaking again? Okay, good. So to be honest, the postpartum psychosis, it's more common than they actually say it is. It's actually more common. So what happens is you have mother who, after delivering the baby, what they can get is they get delusional, they start hallucinating, and they have thoughts of harming the baby or harming oneself. So this is known as postpartum psychosis. The risk factors include first pregnancy, if they have a strong family history, past history of bipolar disorder, psychotic disorder, recent medication changes, okay, hospitalizations, and atypical antipsychotic. Okay, if insufficient, ECT may be used. Okay, basically ECT may be used, and you will not get a lot of questions from postpartum psychosis. It's not that high yield for USMLE step one, but if they tell you a scenario of postpartum diagnosis, if they tell you that you have a scenario for postpartum psychosis, that the patient is delusional and hallucinal and is hallucinating, the patient had a previous history of delivering a child. Okay, now the patient is having thoughts of harming the baby or harming herself, What is your diagnosis? What is your diagnosis? Postpartum psychosis. Okay, that's postpartum psychosis. Okay, good. Okay, good. Next. Okay, good. Next thing I want to talk about is grief. Okay, next thing I want to talk about is grief. Okay, so what is grief? Okay, what is grief? Does anyone know what grief is? Have you guys ever felt grief in your life? Have you guys ever felt grief in your life? Okay. If you me no, then I will not believe you. It's absolutely important to not feel grief. Okay. Okay. So one of the number one cause of feeling grief is losing someone who is close to you. Okay, so Dr. Tarin has said the same thing. That the number one cause of grief is losing someone in your family or friends who is very very close to you. And I'm sure some of us can relate to that. Okay, including myself. So grief is very very common now. As a physician, you have to diagnose grief. Okay, as a physician, you have to diagnose grief. And the according to one researcher, okay, according to one researcher, okay, the name of the researcher was Kubler-Ross. Okay, the name of the researcher was Kubler-Ross. So according to Kubler-Ross, why is the name important? Because this name will be used in your U world. This name will be used in your U world because Kubler-Ross came up with a stage model for grief, okay, which has grief in orders. First of all, first thing is, okay, so the first thing is, let's say, God forbid, we have someone who we love a lot, okay, and let's say that, okay, let's not talk about us, let's talk about someone else. Okay, let's talk about this guy called John. Okay, John really loves Jane. Jane is John's wife. Okay, they grew up together, high school sweetheart, they got married. Okay, and now she is the only person in John's life, and all of a sudden something happens, god, and she passes away. Okay, she passes away. So John has no idea that Jane has passed away. Okay, so John gets a call from the police officer who is at the scene of the hospital, I mean, who was at the scene of the accident. And if the police officer is telling John that Jane has been in an accident and she has passed away. Okay, she has passed away. They're taking the body to the hospital for postmortem. What is the first thing that you think John will say? Is there a possibility that John will say that it's not possible and he will not accept that? There's no way. Okay, so the is first one, denial. Okay, you will not believe that this has happened. Okay, denial. Next. Next comes next comes after the police officer reinsures John that you have to trust me, Jane has passed away. Okay, I'm sorry, but it is what it is. The next thing that John will say to the police officer is something like, let's say that the next thing that John will say to the police officer is that you have absolutely no idea what you're talking about. You're nuts. Okay, I don't know who you are, but I'll find you and I'll kill you. Okay, because the next step in John's reaction is anger. Now John is angry. Okay, so the police officer tells John that, okay, if you don't trust me, why don't you come to the hospital? Why don't you come to the hospital and you see for yourself? Okay, since you said you're going to kill me, why don't you come to the hospital and see for yourself? So John leaves work, rushes to the hospital, and sees his wife Jane just lying over there, lifeless. And when John sees the doctor, when John sees the doctor, John asks the doctor, that doctor, is there nothing you can do? Is there absolutely nothing you can do to bring her back? Okay. So what is the next step of John's grief? What is the next step of John? What is the next step? The next step of John's grief is bargain. Now John is bargaining. John has faced denial. John is no more angry. Now John will bargain. Okay, okay, okay. So that's that. After that, the doctor tells John that I am really sorry. It is what it is. Okay, the accident was very severe and she died unfortunately on the spot. So what John does is John buries his wife. Okay, after that, John undergoes a stage of extreme grief in which John stays home. John does not go out. John has loss of interest. John stops sleeping. John doesn't eat a lot. Okay. What is this next step? Depression. Depression. Okay. After depression, okay, after depression, John realizes, after depression, John realizes that they have a little baby they have to take care of. He has a little baby they have to take care of. So what does John do? Instead of moping around, okay, because he is done being depressed, okay, he has finally accepted it. Okay, finally accepted it. And now John has to be strong, and John has to be strong for their little child, okay, who is an absolutely little baby infant. And John knows that the full responsibility of the baby is on him. Okay, so the next step comes with John moving forward. What is this next step? What is this next step called? Anyone? Okay, a few years later, he comes to term with it, and now it is acceptance. Yes, there we go. So the next one is acceptance. Okay, I'm sorry to make you guys so sad and upset. Okay, but this was just a story. Okay, John and Jane are living happily ever after. Okay, Jane did not die. Okay, so what happened was in that story, when John went to see Jane, okay, what happened was they saw that it was a false accident, it was a false alarm, and it was a it was a prank. Okay, so that's what it was. Okay, so that's what it is. So in the real life, John and Jane, they're actually very happy. They're living together. They have a little baby. So their Jane did not die. Okay. So have you guys understood the stages of grief? Okay. Okay. Do you guys realize how powerful words can be? Like, look, really. Okay. Okay. So once again, John and Jane, they're not dead. We have students over here saying, "Thank God! Oh my God! Okay, yay! Okay." So I'm glad you guys got so attached with fictional characters. Okay, I use John and Jane every day. So don't worry. Okay, they'll stay alive for the next at least 1 or 2 months. Okay, so no problem. Okay, so that's what it is. So these are the 5 stages of grief. Okay, and okay, now let's go back to our text. Okay, now go back to our text. Okay, the 5 stages of the Kubler-Ross model are the ones we just talked about, and they may occur in any order. Okay, but the most common orders are the one they will occur in this one, that is denial, anger, bargain, depression, and acceptance. Okay, that's that. Others, you have some other symptoms, that is shock, guilt, sadness, anxiety, yearning, somatic symptoms, not high yield. Simple hallucinations of the deceased persons are very common. Any thoughts of dying are limited to joining the deceased. Duration varies widely, usually resolves around 6 to 12 months. Okay. Okay. If you have a UL question where they tell you that you have a young child who recently heard about the news of their grandfather passing away, now the young child sees the grandfather all the time, and this has been happening for the last 3 months. What is your diagnosis? What is your diagnosis? Is normal or not normal? Grief. Is grief normal or not normal? So it's normal grief. Very good. Okay, so it's normal grief. Okay. If I tell you now that if I tell you that this young boy now also wants to die because it's been a long time since since he heard the bad news. Now the young boy also wants to die to go and to go and stay with the grandfather because the grandfather meant a lot to him. Okay. Now, is the grief normal or abnormal? Abnormal. Okay, the grief is abnormal. Okay, this is abnormal grief or complicated grief. Okay, so it's very important that you understand what normal grief is and what abnormal grief is. Okay, if these sign symptoms, if they should be present from 6 months to 6 months to 1 year at max. Okay, 6 months to 1 year at max. If they're present for more than 1 year, okay, if they're present for more than 1 year, this normal grief can go to form complicated grief or abnormal grief. Are we clear? Are we clear? Okay. Okay, good. Okay, next one that I want to talk about. Okay, next one I want to talk about is persistent complex bereavement disorder. Involves obsessive preoccupation with the disease and causes functional impairment lasting at least 12 months. Okay, okay. What, let's say that you lose someone who is very close to you, okay, and you go through the normal stages of grief, and this stays for 6 months to 1 year. But after 1 year, you enter that acceptance phase of the grief. Okay, now you're accepting it. So that's normal. Okay. But let's say that after the person has deceased, you are so obsessed, you are so obsessed with that person that that person's thoughts and actions, they are causing your functional impairment. They are not allowing you to go to work. They are not allowing you to eat. They are not allowing you to sleep. They are not allowing you to talk or do anything. Functional impairment, total functional impairment. Okay, is that normal or abnormal? People in grief, do they eat or not eat? People who are in grief, do they eat or do they not eat? People who are grieving on something, do they eat or do they not eat? They do not eat at all. They do not eat at all. Nothing. They eat, but they eat very less. Right. They do eat, but they do not eat any more than what they need. Okay. They do not want to be, they do not want to be happy. They do not want to eat a lot. So they eat exactly needed to go through the whole day. Okay, so more or less. But if I tell you that this person has stopped eating for the last 3 or 5 days completely, is that a functional impairment? Yes or no? So is that normal grief or abnormal grief? Abnormal grief. If this type of grief lasts for more than 6 months, if this type of grief lasts for more than 6 months, then this is called, then what is this called? This is called persistent complex bereavement disorder. Persistent complex bereavement disorder. Are we clear? Is my voice breaking again? Is my voice breaking again? Do I have a broken voice? Okay. Can you guys hear my voice now? Is the voice breaking? Is the voice breaking? Okay. You have a question. Wait, let me come back. Let me come back. Okay, can you guys hear my voice now? Is the voice better? Is the voice better? Okay. Okay, so we were talking about persistent complex bereavement disorder. Okay, persistent complex bereavement disorder, meaning that disorder where the complicated grief lasts for 6 months to 12 months. Okay, so that is persistent complex bereavement disorder. Are we clear? What was the question from the student, the last student who wanted to ask the question? What was your question, please? In first aid, it says versus complicated grief in bracket. Okay, let's see what first aid says. Okay. Okay. So where were we? Okay. Persistent complex bereavement disorder involves obsessive preoccupation with the disease and causes functional impairment lasting at least 12 months. 6 months in children can also meet criteria for major depressive disorder. Okay. I'm not sure which one you're talking about. Okay. Which one are you talking about? Complicated grief. Okay. Mhm. Any thoughts of dying, of a disease, duration of agony usually results in the person. Is it over here in this page or?
Yeah, it's right there. It's any thoughts of dying
Oh,
or
my bad. I'm sorry. This one over here.
yeah.
Any thoughts of dying are limited to joining the deceased versus complicated grief. Yes. Oh, okay. I understand. Okay. Thank you for pointing this out. Okay. So what's going on over here is thank you. So okay. So let's read this line once again. Simple hallucinations of the deceased persons are common. Any thoughts of dying or are limited to joining the deceased versus complicated grief. Okay, so what's happening over here is that in complicated grief, the complicated grief basically is it's more about the duration than the sign symptoms. Okay, so complicated grief is more about the duration than the sign symptoms, meaning that if the grief stays complicated, okay, if the grief stays complicated, for example, that the person is so preoccupied with the deceased, okay, with the deceased, and this stays for more than 12 months for adults and 6 months for children, then it's called persistent complex bereavement disorder. And the thing is, in complicated grief, the patient at times they want to go and join the deceased, but at the same time, you can have also those sorts of feeling which can come in normal grief too, but it all depends on the timing. Does that make sense? Do you understand what I mean? At first, we have to understand what is complicated grief. If the grief lasts for more than 12, if the grief, okay. First of all, what is the normal duration for the normal grief? What is the duration for the normal grief? What is the duration for normal grief? 6 to 12 months. Good. If 6 to 12 months or less than a year, if it continues for more than a year, is it normal or complicated? Complicated. Okay, so basically complicated grief is more than 1 year. That is complicated. Now, out of all of this, if the patient wants to join the deceased, the patient also wants to kill themselves. Okay, if the patient also wants to kill themselves after 1 year, is that abnormal or normal? Abnormal. Okay, so that is basically what can happen in complicated grief. Also, is it possible for the patient to think about killing themselves in normal grief? Have you heard? I mean, i'm sure you have heard I'm sure you have heard people who lost their husband or their wife, and they said that, okay, I don't want to live anymore, I want to die, right? Like, I want to pass away, I want to go and stay with them. So even during that time, it's still normal, because the duration is between 6 months to 1 year. He or she is saying stuffs like this in that duration of 6 months to 1 year, so it's still normal. It's not complicated. But if they keep on saying stuff like this more than 1 year, then that's complicated grief. Now, does it make sense? Okay, perfect, perfect. Okay, now, are you guys confused about complicated grief and persistent complex bereavement disorder? Okay, if I tell you that you have a patient who is grieving, but the patient does not have functional impairment and it's been more than 1 year. What is your diagnosis? Patient is still grieving, complicated or abnormal grief. If I tell you that it's been more than 1 year, now the patient has functional impairment, the patient still cannot get up from their bed, the patient cannot still go to work, persistent complex bereavement disorder. Okay, okay, it's quite a topic today, to be honest. Like I thought we were gonna have fun. I was having a little bit of fun, but to break all of this down is extreme. Okay, but are you guys understanding the topics? Okay. Okay, it's exhausting, but it's extremely important that you understand the whole thing, that you understand the duration. Because do you realize how complex this whole thing is? If you read it, it would look very easy to you. But if you try to break it down and try to understand everything, then it's a bit difficult. Okay, so the best thing that we can have right now is patience. Patience. Okay, patience. Next one. ECT. ECT is electroconvulsive therapy. What is electroconvulsive therapy? This is basically a rapid acting method to treat refractory depression, depression with psychotic symptoms, catatonia, and acute suicidality. Okay, that's what it is. It's not that high yield for step one. Just read through it to see what's up. It induces a tonic-clonic seizure and neuromuscular block. Adverse effects include disorientation, headache, anterograde and retrograde amnesia, which will resolve within 6 months. No contraindication and safe in pregnant and elderly individuals. But do we use ECT nowadays? Yes or no? Do we use ECT nowadays? Okay, so is it important for USMLE step one if we don't use it? Okay, not that important. Not that important, but then again, USMLE step one is very unpredictable, but I have not received a single question about ECT. Okay, so that's that. So let me know if you guys receive any question about ECT, and then we can talk more about this in details because we have more important topics to go to. Okay, next one. Next one is risk factors for suicide complications. Okay, risk factors for suicide complications. Who are the patients who are more prone to commit suicide? Okay, commit suicide. Okay, number one. Number one, okay, out of male or female, who do you think are more prone to commit suicide according to statistics? Suicidality. Men. Okay, first of all, okay, number one. Okay, males. Number two. Number two is age. Okay, who are the group of men or group of people who are more prone to commit suicide? That is young adults. Okay, young adults. Okay, why young adults mostly have a lot of hormonal distributions that are going throughout their whole body. Okay, they're very impulsive. Okay, they do not know what to do. They think they think that they think that falling in love or breaking up with someone is the end of the world. Okay, or failing an exam is the end of the world. Losing a parent is the end of the world. Everything is the end of the world for them. So young adult, that's one. Another one is young adult or another group of people are old people or aged people. Okay, so elderly people. As a matter of fact, what is the number one cause of death for elderly people in USA? Yes, that's cancer. It's actually not suicide. Okay, so it's cancer. Okay, it's not suicide. Okay, so suicide is not the number one cause of death for elderly people. It's cancer. That's that. Okay, but having said that, the number one risk factor for if I have to ask you, who are more prone, young adults or old people? Young adults or old people who are more prone to undergo suicide. Anyone? Adults. That is correct. Old people more common. Okay, old people, they're more common. Next one. Next one is history of depression. Okay, history of depression. Okay, that makes sense. Then number four is history of suicide attempt, history of previous suicide attempt. Okay, number five. Okay, number five is alcohol or drugs. Number six. Okay, psychotic. Okay, psychotic. Okay, so how many? Sex, age, history of depression, history of suicide. Then we have alcohol or drug abuse, psychosis. Okay, next one, sickness, long-term sickness, for example, long-term cancer. Okay, long-term debilitating illness. Okay, eight is plan to commit suicide. Okay, they will tell you that they will plan, that they have a certain day, date, and time. That's that. Nine, no support. No support meaning no husband, no wife. Okay, no family support. Very scary. Number 10. Number 10 is no goals. They will have no future goals. Are we clear? Mm, Are we clear? Okay. Are we clear? So, is this something you have to remember for USMLE step one? Yes. The answer is yes. Okay. You have to remember this for USMLE step one because you will get tested on the risk factors. First of all, first of all, first of all, let's talk about the sex very fast. Sex, is it male or female? Okay. Then age. What about the age? Okay, good. Then history of depression or no history of depression? History of depression, very good. Should they have a previous attempt of committing suicide or not? Yes or no? Yes, okay. Alcohol or drug abuse? Yes or no? Okay. Then what else? If they have psychosis, is that a risk factor? Psychosis? Okay. If they are very sick for a long period of time, is that a risk factor? Okay. If they tell you they'll commit suicide in this very day at this very date, is that a risk factor? Yes, it should not be taken lightly. We have friends or we have people who make fun of suicidal people. And if someone comes and tells you, yes, I will commit suicide in this very day, at this very date, and they're being very specific that at this very place, and you laugh at them and then you tell them, okay, yeah, whatever, do whatever you have to do. Okay, because I know that you don't have the guts to commit suicide. That is one of the worst things. That is one of the worst advice you can give to a suicidal person. Okay, that is one of the worst advice you can give to a suicidal person. So since we are learning ourselves, it's also our duty to teach other people that there are certain ways that you should deal with people nowadays. Okay, because with everything that's been going on, people are more sensitive. Okay, so yes, especially people on social media, one of the worst people are social bullies. Okay, you would be surprised. Dr. Tarian, who says that? Okay, so you would be surprised. Okay, you would be surprised how many people undergo um, depression just because of not having support from their friends and family. Okay, next one is if they don't have a husband or wife, is that a risk factor? Yes or no? Okay, okay. And if they do not have any goals in their life? Okay, good. Okay. Another one is, do you guys know the number one cause of death? I mean, the number one way by which Americans commit suicide? Mostly. Very good. Access to firearms. Okay. So one of the amendments of a U.S. citizen. Can anyone tell me which amendment of a U.S. citizen is to have the right to bear a firearm? To have the right to bear a firearm. Okay, you have the right to bear a firearm. Okay, it's the Second Amendment, meaning I have the right to have my own gun. Okay, gun, firearms mean gun, meaning guns. Okay, so most states of the USA, they do not, they allow people to carry guns, except New York. Okay, so these are some of the things which you guys should know too, since you guys are planning to being the physicians. I mean, you as physicians. So that's that. Okay, so it's one of the right of of US citizens. It's one of the amendments to bear firearms, and the number one cause of death in US is due to self shooting by their own firearms. Okay, so if I tell you that you have a suicidal person in your house, do you have to hide that firearm? Yeah, yes or no? Yes. Okay, is that a you world question? Yes or no? Okay, that's a you world question. Okay, that's a you world question. Okay, that is a you world question. Okay, that's what it is. Okay, now next question is women and men. Okay, out of women and men, who tries to commit suicide more often according to the statistics? Who tries to commit suicide more often but does not succeed as much as the other one? Women. Who succeeds in committing suicide? Men. Okay. Okay. Is that a question from Amboss? Yes or no? Yes. That's a question from Amboss. Okay. I'm not just throwing away informations at you guys. Okay. I'm not just throwing informations. Okay. I'm actually discussing questions. So that's what it is. Okay. Next, good one. Okay, having said that, okay, feeling really down right now, okay, like proper downer feelings. Let's move on. Okay, let's move on to the next one, that is anxiety disorders. Okay, let's move on to the next one, that is anxiety disorders. Are we clear about suicide, depression, bipolar, schizophrenia, schizoaffective, brief psychotic, schizotypal, schizoid? So what else did we learn today? Delusional disorders, grief, complicated grief, okay, persistent complex bereavement disorder, bipolar type 1, type 2, cyclothymia, dysthymia. We learned a lot of terms today. Are we all clear about these terms? Are we all clear about these terms? Are we clear about manic episodes, hypomanic episodes, the depression? Okay, good. Okay, if we are clear, then let's move on to anxiety. Okay, now let's move on to anxiety. Okay, okay, anxiety. Okay, what is anxiety? It's the inappropriate experience of fear or worry, and the physical manifestations with the magnitude of the stresses. That is an extremely amazing way that first it puts the whole thing into words. Basically, let's say let's say that everyone has a stressing point in their life. Yes or no? Everyone is stressed out about something. Yes or no? Okay. Okay. But your response should be equal to the magnitude of the stress. Yes or no? Your response to the stress should be equal to the magnitude of the stress. Depending on how stressful the situation is, your response should be equally of the same magnitude. But let's say that you get so stressed out that your response is of such a high magnitude that it's way bigger than the magnitude of the stress it's causing you. That is anxiety. Okay, that is anxiety. Are we clear? Are we clear on anxiety? Okay, good. So the symptoms are not attributed to any psychiatric disorder, medical conditions, or substance abuse. It includes panic disorder, phobia, generalized anxiety disorder or GAD, and selective mutism. So these are the four criteria of anxiety disorders. Okay, one second. Let me just charge my laptop. One second, please. I mean, just let me take my laptop out of charge. Okay, perfect. Okay, so that's what it is. So the thing is, anxiety disorders can be classified into panic, phobias, generalized anxiety, and another thing that we learned was selective mutism. Now, number one is panic disorder. What is panic disorder? This is a disorder in which the patients have recurrent panic attacks involving intense fear and discomfort. Okay, intense fear and discomfort. Have you ever had a panic attack? Has anyone ever had a panic attack in their life? Okay. Okay. So panic attack. Okay. So basically, it's almost the same sign symptoms as patients feels when they have bronchial asthma. Okay. They feel that they cannot breathe. Okay. Chest tightness. Okay. Fear of impending death. Okay. And then these are the signs and symptoms of panic disorder. The recurrent panic attacks if they keep on having with intense fear and discomfort with or without a known trigger, then it's the disorder. This disorder is known as panic disorder. And the thing is, it peaks in 10 minutes with four or more of the following. That is, what are the following signs symptoms of panic disorder? Number one. Number one is palpitations. Okay, number one is palpitation. Then number two is paresthesia, depersonalization, derealization, abdominal pain, nausea, intense fear of dying, intense fear of losing control, lightheadedness, chest pain, chills, choking, sweating, shaking, shortness of breath. Okay, you do not have to remember everything. Okay, first of all, can you guys tell me the sign symptoms of a sympathetic innervation? What happens in the heart? Sign symptoms of sympathetic innervation. Increased tachycardia. How about the respiratory rate? Increased sweating. Okay. Then what else? Shaking. And does it increase in sympathetic activity? Yes or no? Increase. Okay. So the next time you want to think about the sign symptoms of panic disorder, think about the sympathetic innervations of your body. Okay, basically your whole body when it's in a sympathetic state of mind. That's your sign symptoms of panic disorder. Okay, now this is important. How do you diagnose a panic disorder? In order for you to diagnose a panic disorder, this would require an attack followed by 1 month or more of the following symptoms. What are the following symptoms? That is persistent concerns, worrying about the attacks, and behavioral change related to the attack. Okay, so when do you call a panic attack a panic disorder? When do you call a panic attack a panic disorder? Number one, you call a panic attack a panic disorder when when first of all, this attack has to occur at least once. Okay, this attack, this type of breathlessness. Okay, this type of breathlessness, and then choke, and then shortness of breath, increased respiratory rate, sweating, shaking, sense of impending fear or death, they should occur at least once, followed by, there should be one of three criteria. First of all, if you are scared that you will have this attack again, that is one. Number two, if you are persistently concerned that whether this attack will hamper your functional or occupational life, that is number two. And number three is your behavior changes, that you know that you are precipitating an attack, that this type of attack will come. So your behavior changes. You start to think that you need to take actions in order to decrease these type of panic attacks. Then this panic attack, if you have one of these three criterias, then this panic attack is now known as a panic disorder, not an attack. Are we clear? Are we clear on this? Okay, so panic attack and panic disorder, they are not the same thing. Okay, if you are constantly worried about your panic attack, that's one. If your behavior changes in order to decrease the episode of panic attack, that's two. And if you're so concerned about your panic attack that they will hamper your occupational life, or your work life or your home life, then if you have one of these criteria, then you have a panic disorder. You do not have panic attacks anymore. Okay, the treatment is very easy. Okay, panic attack treatments, thank God, are very easy. The number one is CBT, that is cognitive behavioral therapy. SSRI, venlafaxines are SNRI. Okay, that's that. Benzodiazepines are occasionally used in acute setting, but long-term treatment is by CBT and SSRI. Okay, are we clear on panic attack and panic disorder? Okay, next one. Next one is phobia. What is phobia? Phobia is basically the severe or persistent fear or anxiety due to the presence of an anticipation of a specific object or situation. How many of us over here are scared of insects? Insects, creepy crawlies. Okay. 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 So if you are right, cockroaches, especially the flying ones. Okay, this scares shit out of me. Okay, so flying cockroaches are my phobias. Okay, so that's what it is. So the thing is, if you are so scared of a if you are so scared of a specific object or a specific situation, if you're scared of a specific object or a specific situation, and that fear or anxiety related to that specific thing, let's say for me it's flying cockroaches. Okay, and if that stays for more than 6 months, which it did, so it's a lifetime of fear. So my specific phobia is to flying cockroaches. Okay, or so your specific phobia is to lizards or snakes. Okay, so that's what it is. Are we clear on specific phobias? Okay, good. Good. Next one. Next one is, how do you treat a patient with specific phobia? How do you treat a patient with specific phobia? Right now, if I want to treat my problem of flying cockroaches, if I really wanted to get over them, what I would do is I would lock myself in a room filled with flying cockroaches. Okay, sounds like hell, but I would do it, because if the only way I can treat myself is CBT, meaning cognitive behavioral therapy, with repeated exposure. With repeated exposure, if you repeatedly expose yourself to the stressor, then eventually what would happen is your body and your mind will realize that it's nothing to be worried about, and your phobia will go away. Okay, are we clear? Repeated exposure. Okay, good. Next one. Next one I want to talk about is, okay, the next one I want to talk about is social anxiety disorder. What is social anxiety disorder? This is basically your exaggerated fear or embarrassment in social situations. So what happens is, if you go to if you're asked to give a speech, let's say at a public speaking, or you're asked to use the public restroom, you get socially anxious and you can't do it. Okay, so that is social anxiety disorder. Okay, and people with social anxiety disorders, will they be able to come outside their house? Yes or no? Yes. Yes, people with social anxiety disorders, they will be able to come outside of their house. How about people with agoraphobia? Will they be able to come outside of their house and stay in open or closed spaces or use public transports? No. Okay. No. There's no way people with agoraphobia can come outside of their house. So there are two things which you have to understand from this. Number one is social anxiety disorder. Another one is agoraphobia. What is it? Social anxiety is basically you're anxious to be on spot. Do you know the phrase on spot? Okay, so if someone puts you on spot. Okay, have you guys ever used the phrase, "Hey, you just put me on spot"? Okay, put me on spot, meaning that everyone's attention is towards you, and now they're all expecting you to say something. Okay, and then if you say it, you do not have social anxiety. But people with social anxiety, if they're ever put on spot, they will never be able to say anything. Okay, so that's what social anxiety disorder is. The treatment is very simple. Once again, CBT, SSRI, venlafaxines. Okay, and sometimes what happens is, if you have, this is a UWorld question. So this is a UWorld question. High school graduate has to give a public speech. The high school graduate has a social anxiety problem. Which drug will the graduate take in order to calm his nerves so that he can give the speech properly in the setting of in the setting of public speaking? Beta blockers. Very good. Beta blockers, what they will do is they will take beta blockers or benzodiazepines to calm their nerves, and then this will allow them to speak properly. Okay, so that's that. Okay, having said that, should you guys use should you guys use beta blockers during your USMLE step 1 exam? Yes or no? Okay. Okay, anyone else? Okay. Please do not use any performance enhancing drugs in your USMLE step 1, such as beta blocker or benzodiazepine. I'm pretty sure you guys will never use benzodiazepine. It will put you to sleep. Okay. So what beta blocker will do is, will beta blocker decrease your sympathetic activity? Yes or no? Sympathetic activity, beta blockers. Okay. So the thing is, do you need your sympathetic activity when you give when you are giving your exam? Do you need that fight or flight? Okay. Is assembly step one not a fight? Yeah, yes or no? Okay, it's a fight. Okay, it's a fight. So you need your sympathetic activity to to override your exam so that you can also give the answers with proper confidence. If you don't have adrenaline, you don't have confidence. Okay, if you don't have confidence, you don't have the right answers. Okay, so please don't take any drugs. Please don't take any drugs. I know a lot of students who goes to take calming drugs, who calms their nerves or do whatever, and then they mess up their whole exam. Okay, so don't do stuff like that. Okay, don't use beta blockers. The thing is for public. Okay, Ritalin, I'm not sure what that drug is, but I highly advise you to not take it. Okay, they say it makes you focus. I'm not sure. I advise you guys to not take any drugs. Please focus on by the way that you guys focus. Okay, so that's what it is. Okay, good. Next one is agoraphobia. Next one is agoraphobia. That is your anxiety while facing, anticipating two or more specific situations. That is open or closed spaces, lines, crowd, or public transport. Okay. So if I tell you that agoraphobia is a more extreme form of social anxiety disorder, is it true or not true? Yes. Okay. Agoraphobia is a more extreme form of social anxiety disorder. In social anxiety, you have a problem going up and speaking in public. People with agoraphobia, they can't even come outside of their house, stand in lines, or go to open spaces, use public transport. Okay. They refuse to leave their homes. In severe cases, they refuse to leave their homes. So agoraphobia is a severe form of social anxiety disorder. Okay. Okay. Are we clear on social anxiety disorders and agoraphobia so that we can move on to GAD? GAD for general anxiety disorder. Okay. Generalized anxiety disorder, excessive anxiety and worry about different aspects of life, work, school, children, for most days, that is more than 6 months. And it is associated with three or more of the following for adults. Okay. That is restlessness, irritability, sleep disturbance, fatigue. Okay. Sleep disturbance, fatigue. 1 second. Muscle tension, difficulty concentrating. Then this can be called as generalized anxiety disorder. How many of us have these kind of problems? Does anyone have these kind of issues? You're excessively anxious and you're excessively worried about your work, about your school. If you have any child, then you're very worried about your child all the time. Okay. And that thing is, you're so worried that you are worried on most days, that is for more than 6 months or more. Okay. Along with this, you have restlessness, irritability, it affects your sleep. Okay. So, yeah, of course, step one does that to you. Yes, of course it does. Okay. But okay, that's that. But having said that, some people have problems like this with their daily life. Okay, I mean by that, meaning that the fact that let's say some people have to go to work and they're anxious about how they will go to work. There's no need to get anxious about how you'll go to work. You'll go to work exactly like how you go to work or how you went to work the previous day. You will do the same thing that you did today. So that's what it is. So some stressors which are not supposed to stress them out, they stress them out so much that they get functionally impaired. Okay, and they stay like this for most days on occasion of 6 or more months. Along with this, they can have restlessness, irritability, sleep disturbance. Okay, that's that. Okay, right. Yes, moms have it hard. That's what it is. So, do you guys did you guys understand generalized anxiety disorder? Yes, no. Okay. Okay. Treatment for generalized anxiety disorder, CBT, and SSRI. Okay. Then clomipramine and venlafaxine. Okay. Next one. Next one is, have you guys heard about certain people Okay, have you guys heard about certain patients who are never happy with the way they look? Okay, they are never ever happy with the way they look, so they keep on working on themselves. Okay, and they feel like they do not belong in this body. Okay, they do not feel like they belong in this physique or in this body, and they keep on trying to do surgeries and change themselves again and again and again and again. Okay, so no matter what they do, they are never satisfied by how they look. Okay, that is also a problem. Okay, and it's also a disorder. This disorder is known as body dysmorphia or body dysmorphic disorder. That is preoccupation with minor defects in appearance. Let's say a person. Okay, let's say, do you guys know any famous celebrity who keeps on doing this? Anyone? Do you guys know any famous Michael Jackson? Okay, okay, okay. Good. So what happens is, let's say this is the person's nose. Okay. Okay, and we all know that symmetrical that a person is identified as beautiful on social media or anywhere else is if they have perfect symmetry of everything. Okay, if they have perfect symmetry, meaning strong jaw, sharp nose, good hair. Okay. Okay, is it always important to have a symmetrical face to look in a certain way, to look nice or to look beautiful? So no. No. Okay, should you accept how you look? Yes or no? Yes. Okay, because that's who you are. You should own who you are. Okay, so more or less that's what it is. But having said that, people have the right to do whatever they want. Okay, so what happens is, some people, they want to change, and then they want to achieve this sort of body symmetry. Okay, they want to achieve this sharp nose, sharp jaws, proper lips. Okay, so they keep on making changes to their body slowly, again and again and again and again. And what this happens is, over time, this causes significant emotional distress. And this repetitive appearance related behavior, meaning mirror checking, and what they will do is they will always check themselves out in the mirror. Okay, feel the need to excessively groom themselves. Okay, that's what it is. And the treatment is very, very easy. Okay, the treatment is very easy. The treatment is cognitive behavioral therapy, CBT. Okay, cognitive behavioral therapy. Are we clear on this? Are we clear on body dysmorphia? Okay, are you guys understanding the lecture for today, or is it too much? Or okay, okay. Okay, understanding it, good. Okay, I did not miss OCD. Okay, I'm gonna talk about OCD right now, but I just wanted to talk about dysmorphia because it went side by side. Okay. Okay, enough for today. Just a little bit more, and then we would be done. Okay, just a little bit more. We will talk about two more things, and then we'll be done. Next one. Next one I want to talk about is, okay. Have you guys ever? Okay, instead of studying, let's have stories. Okay, let's talk about a story. Okay. Have you guys ever seen a person who has to switch who has to use the switch of the light? I mean, who will turn on and turn off the switch of the light exactly 5 times or 7 times every time before they leave or enter the room? If they don't do that, okay, if they don't do that, they believe that someone in their family will die. Okay. Have you heard of people like this? Okay. Okay. Okay, so what is this? Okay, so just out of curiosity, what is this word? What is this word called in each of your languages? Well, what is this word called in each of your languages? Let's see if I can get obsession. Sure, but I just want to know any word for obsession in this type of problems. I know that every language has a word for this. Okay. Okay, so we have one. Okay. Okay, Dr. Hassan, there we go. Shoot you by. That's what it is. That was the word I was looking for. Okay, so that's what we use. That's what we used to call people in our community who had this type of problem is Shuchibai. Okay, so that's what it is. Okay, so just wanted to connect with you guys to see what you guys use. Okay, so Shuchibai is what we use. So basically, that's what it is. So the problem that I'm talking about is obsessive compulsive disorder. The problem I'm talking about is obsessive compulsive disorder. So these people, okay, all jokes aside, this is not something which should be taken very lightly because obsessive compulsive disorders are very, very common. And some people also have another type of obsession. Okay, okay, that's that all. Okay, good. Right. Okay, so as I was saying, that some people have another type of obsession that they always feel the need to wash their hands. Have you seen these type of people too? They have to wash their hands all the time. They keep on washing their hands so much. They keep on washing their hands so much that they actually cause physical harm to their hands. Yes, they have cracks and everything. Okay, so that is also another type of obsession. Okay, and these obsession, they can cause severe distress and they're relieved by compulsions. Compulsions meaning performing the obsession over and over again. Okay, so ego dystonic. Another one is behavior which is inconsistent with one's belief and attitudes versus obsessive compulsive personality disorder. Okay, and what happens is this behaviors are not consistent with the one's belief and attitudes. And if that's what it is, then this is known as ego dystonic. Okay, this is not that high yield. You don't have to differentiate between ego syntonic and ego dystonic for USMLE step one. Just understanding OCD is enough. Okay, OCD is enough, obsessive compulsive disorder, and you will be tested accordingly. Where they will tell you, they will paint a patient scenario where they will tell you that you have a patient who feels the need to turn the switch on and off 5 to 6 times every day because if he doesn't do that, he firmly believes that someone in his family will pass away. So something absurd as this will direct you to the disorder that is obsessive compulsive disorder. That's what it is. Are we clear on obsessive compulsive disorder? Okay, good. Next one. The last one is trichotillomania. Okay, trichotillomania. Okay. I personally have a grandmother who has trichotillomania. So what happens is when she is stressed out or thinking about something, she goes into a haze where what she does is she starts thinking and she starts pulling her hair away. She starts thinking and she keeps on pulling one strand of hair one by one. Okay, and she keeps on doing it. And what happens is eventually patients have this whole area of hair of the scalp which has no hair. Okay, can you differentiate this with with alopecia? Doesn't it hurt? At one point, it does not hurt. Androgenetic alopecia. Can you differentiate this? Yes. Okay. In patients with androgenetic alopecia, let's say this is a temporal view, they will have spots over here. They will have small spots, and then this will keep on rising up like this. Okay. Another one is in androgenetic alopecia, they will still have hair. Okay, they will still have like a bed of hair, but in trichotillomania, they will have a shiny head. The head will be completely shiny. Why? Because the hair has been pulled out from the follicle. Do you see this shiny area over here? The shiny area. There's absolutely no hair follicle in this area. So this is all. This will direct you to trichotillomania. Okay, so that's what it is. You will get a question in UWorld where they will try to assess whether you know the difference between alopecia and trichotillomania. And the way you can answer that question right is you have to look for a stress. You have to look for a stressor. Okay, if you see that your patient in the UWorld is stressed out, okay, then your patient has trichotillomania because he is persistently pulling the hair. Are we clear about trichotillomania? Are we clear about trichotillomania? Okay. Treatment. Treatment is psychotherapy. Okay. The treatment is psychotherapy. Okay. It's not that high yield. You will get one question about trichotillomania in UWorld where they would assess you whether you know the difference between androgenetic alopecia and trichotillomania. And they will complain about stress. Okay. And if they do that, and if you see that the scalp is shiny, then your patient has trichotillomania. That's that. Okay. Okay. We're very close. Do you guys want to continue forward or stop over here? What is your question? Yes, Dr. Jordan, what is your question? Okay, we won't go. Okay, so stop, please. Okay, so we will stop. Okay, no problem. I will not teach you against your autonomy. Okay, I have to respect your autonomy. Okay, so that's what it is. Okay, okay. Okay, so let's answer Dr. Jordan's question. Dr. Jordan, first of all, what is egosyntonic and what is dystonic? Okay, egosyntonic and ego dystonic. Okay, first of all, does every person have their own set of rational beliefs? Yes or no? Okay, good. Every has their own set of personal rational beliefs. Okay, okay. If you perform an action that is in terms of your rational beliefs, that is known as egosyntonic. Am I clear? Am I clear? If you perform an action that is against your rational beliefs, okay, that is ego dystonic. Can you give an example? Can I give an example? Okay, so first let's talk about rational beliefs. Okay, so what are the regular rational beliefs? Do you guys have anything in mind? For example, what is, can you guys give me some examples of your rational beliefs? Stealing is wrong. Okay, so that's a belief. Okay. Okay. So if you tell me that stealing is wrong, now you have an OCD to steal something. Is that ego syntonic or ego dystonic? Okay, Dr. Jordan. First of all, Dr. Jordan, the example provided by her is actually pretty good. Stealing is wrong. That's her rational belief. And quite frankly, that's also my rational belief. Okay. I'm pretty sure you guys also believe the same way. Okay. So if you have an obsession and if your OCD is to steal or misplace things all the time, okay, is that going against your rational beliefs? Yes or no? Yes. So if it goes against your rational belief, is that ego dystonic or ego syntonic? Okay, perfect. So having said that, you won't be tested on this in USMLE step one. So you do not have to know this. Okay, but it's good to know everything. I mean, if you have any confusion, of course you should clear it out. Okay. Okay, so what we will do is we will stop our lecture over here. Okay, why did you guys get so tired so fast? Okay, I was thinking of taking the lecture to 2 because we started at 9:45 today. I'm not sure if we have done enough. Have we done enough? I'm not sure if we've done enough. Okay. Okay, fine. We will stop. Okay, because the thing is the reason why. Okay, let me tell you why it's important that we stop. Okay, because for the students who do not want to learn further, okay, I can read through the topics and they'll just keep on staring at the screen and it will not make sense. And it's important that everyone understands what's going on over here. Okay. Okay, so no problem. Okay, so we will stop over here. But having said that, we have to work a little bit harder tomorrow because we have to finish psychology very fast. Okay, we cannot be stuck on psychiatry for a week. Okay, so we have to finish psychiatry. So that's what it is. So we will work very hard tomorrow, hopefully. Okay, and we will try to finish psychiatry by tomorrow. Okay. Okay. Having said that, so right now, okay, do you guys want to do your world notes or questions? I think questions should be a good idea. Okay. Questions? Okay. Okay. Okay, good. Okay, let's. Mhm. Okay, Dr. Iman, would you kindly unmute yourself and ask me the question while I prepare the question, please?
Yeah,
Could
I'm asking about yesterday question about splenomegaly.
Mhm.
Yeah, I think it's not allowed for doctor to skip the patient and tell his coach.
Okay, why?
Yeah, because I can only say if it like sexual transmitted disease or anything like that,
Mhm.
but I can't tell other people that the patient have splenomegaly and he in risk.
Okay, perfect. Okay, thank you so much for your question. So you have a confusion, and I'll be more than happy to clear it out for you. Okay, so we had a question yesterday for all the students who have zero idea what we're talking about. First of all, we had a question which we solved in UWorld yesterday. The question was regarding a patient who had mono, meaning the patient had fever, hepatosplenomegaly, okay, and most probably an Epstein-Barr virus. They did not specify that infection over there, but the patient had splenomegaly. So, depending on the fact that the patient was a football player, the patient was supposed to play a big game. He was a quarterback. And the question was about an ethical question whether the doctor should announce this problem to the coach or not. Okay. Now, according to statistics, patients with splenomegaly, if they play contact sports, is the is the possibility of having a splenic rupture very high or very low? Very high. Okay, it's very high. If you have a patient with a splenic rupture, is the possibility of dying or mortality a high possibility or low possibility? High possibility. Okay. Having said that, if that's what it is, then it's the doctor's responsibility to let the coach know because the doctor cannot make the player play. The doctor cannot make the player do anything. It's the coach's choice. So, but it's the duty of the doctor to let the coach know that this player is not fit to play contact sports. After that, the responsibility of the doctor is done, and um, this will and after that the coach can later decide whether the player can play or not, and that's what it is. But it's the doctor's responsibility to do that. Number one. Number two is how does it not contradict or conflict with patient autonomy? That was the question provided with Dr. Iman, asked by Dr. Iman. That is, how does it not conflict with autonomy? So, what is autonomy? First of all, autonomy is the patient's right to make decisions for themselves. That is that is in regards to treatment, and that is in regards to the procedures. Okay, let's say a patient is against colonoscopy. No matter what you do, if the patient decides the patient will not have colonoscopy, the patient cannot have colonoscopy, and that is you respecting the patient's autonomy. But if the patient is at risk of dying, okay, let's say if the patient is suicidal, okay, will you report this to suicide prevention, yes or no? If you get a suicidal patient,
Yes.
Yes. Okay. Okay. So that's what it is. So the same way, this high school player who wants to play contact sports after understanding that the patient has he has splenomegaly and contact sports will cause splenic rupture. If he wants to keep on playing, then it's more or less suicidal because he's not understanding how big the problem is. So it's the doctor's responsibility to let the coach know. Okay, that's that. Okay, Dr. Iman, could I answer your question
Yeah,
perfectly, or
thank
do we
yeah,
have any
thank
more
you.
question?
No.
Okay, no. Perfect. Thank you so much for asking that question. Okay, that's what it is. Okay. Having said that, give me 2 minutes. Let me just prepare the questions. Okay, are you guys back from that short break or whatever it was for 3 minutes? Okay, good. And can you guys hear my voice? Okay, great. Okay. Um, so one thing before we wanted to begin the UWorld offline questions, it's we are going to solve the ethical questions over here right now, along with some of the psychiatric questions because ethics and psychiatry are more or less together. That's number one, which I wanted to talk about. So we will talk about some things which we have not discussed as of yet, and we will discuss this in the future. But it's good to encounter questions regarding those topics. Okay, that's number one. Number two is for the students who have not sent us an email for extension as of yet. Okay, so the thing is, either we need the students to complete transactions. That's number one, and if anyone fails to complete their transaction, all they can do is send us an email to let us know that they need more time to complete their transaction for this week, and we will gladly allow them to send us to continue with us for this week. Okay, but what happens is if we fail to receive an email for of extension from the students, we immediately assume that you are not interested in doing the classes with us anymore, so we do not want to bother you by sending you lectures or sending you Zoom links. Okay, So the thing is, if we have anyone over here today who needs extension, because today is the last day for giving out the Zoom URLs to the students who have not sent us an email for extension. And after this, if we do not get any email regarding the extension of transaction or completion of transaction, we will not send out the Zoom URLs. Okay, just wanted to state it out. Okay, having said that, let's not waste any more time. Are we all ready to start the UWorld offline questions? Okay, good. Okay, how many of us are well acquainted with the healthcare insurance system over here in USA? Medicare, Medicaid. Okay, okay, okay. Good. Let's start. Let's see how well we can answer this. So first of all, what I would need you guys to do is unmute yourselves and give me the proper answer. Okay, because this would save me some time in going back to the chat box and see where we stand. Okay. Okay. So can you guys see this question over here?
Yes.
Yes.
Let's start with the question. Which of the following insurance options would be the most appropriate for this patient? This is a UWorld exam, UWorld question. Health maintenance, Medicare, Medicaid, point of service plan, PPO, preferred provider organization. A 25-year-old woman comes to the office for follow-up of type 1. She takes long and short-acting insulin with good glycemic control. She also has a history of hypothyroidism for which she take levothyroxine. Okay, not important as of right now. The patient has been covered under the patient's medical insurance for the last several years, but she recently started working full-time for a company that provides a broad variety of employee insurance choices. She requests advice in choosing a health insurance plan. The patient has no disability and says that her main priority is low monthly payments. So she wants to make low payments. Which of the following is the option for this patient now? Let's see what your answer is. After that, I will explain each and every insurance program we have in USA. Which one is your answer?
E.
Medicaid.
Maybe E.
Yeah. Then what else? Are we done? Are we done?
Yeah.
Does anyone have any other opinions? Okay, first of all, what is Medicare and what is Medicaid? Who has an idea about Medicare and who has an idea about Medicaid?
I think Medicare is for
Medicaid
seniors.
is free. Mama. Mama.
I think Medicaid is.
Everywhere.
Medicaid is free.
1 second. Okay. Okay, that was a mess.
I think Medi-Aid is
Oh,
for
that's
people that are like on social welfare. And then
Medicare is for
Medicare
who?
is for people that are like seniors.
Okay, I apologize. I'm so sorry. I could not hear your explanation. Could you please repeat that?
I think I'm not too sure. So I think Medicare would be for like elderly people like over 65, and Medi-Aid would be for people that are like under social assistance and welfare. Like they would get the aid, and then the care would be for caring for older people.
Perfect. Okay, so that's exactly what it is. As a matter of fact, that is what it is. So first of all, the mnemonic, which first of all, let me thank Dr. Tarian for that explanation. So that's what it is. Okay, and okay, so that's what it is. And first of all, the mnemonic that maybe you should use is USA cares for old people. Okay, if you can remember this mnemonic, then you should never have a confusion on Medicare and Medicaid. So Medicare care is for elderlies above 65. Okay, regardless of their job. Okay, they have a good insurance. This is Medicare. They will get Medicare. Medicaid is anyone with a low income. Low income who does not have a job, especially, let's say, every citizen of the United States of America, regardless of their job status, should be able to get Medicaid, keeping in mind that they should be a citizen or they should be a permanent resident, meaning a green card holder. Okay, so Medicaid for low income. If they have a high income, now let's talk about the premiums. So we have three things we want to talk about. First of all is PPO. PPO is personal provider organization. Then we have HMOs, that is health maintenance organization. And next we have POS. POS is point of service. Okay, money. Let's talk about the money, meaning the monthly premium which you need to have for each of these ones. Personal provider organizations. We have terms called in-network provider or out-of-network provider. Okay. Okay. Now, can I have the students unmute themselves and please try to please don't please try to make a little less noise so that I can hear your answers. Okay. So first of all, let's ask the students over here. Okay, if I tell you that you can make an appointment with a specialist without an appointment with a PCP, is that possible? Yes or no?
Yes.
Okay, it's possible, but will it be expensive? Yes or no?
Yes, it will be
Yes, sure.
Okay.
Yes.
If you want to go and see a specialist without referring or a referment from PCP, that is something that will be extremely expensive. Okay. And personal provider organization provides, okay, if you have a PPO monthly premium, then you can go and visit whoever you want. Okay, you can go and visit whoever you want. And the usual monthly premium that you can pay is $900 per month. Okay, that's just an estimate, $700 to $900 per month. Next is HMO. HMOs are health maintenance organizations, meaning that, have you guys heard of 401k benefits?
Yes.
Yes.
Okay, so what is 401k benefits? They
Retirement
have
plan.
dental, eye, health, right? And basically, if you try to get into any job, they will pay for your monthly health insurance, right?
Yes.
Now,
Yes.
including the benefits, that's what they mean. They have so this is your lowest premium that you can pay. Let's say a monthly premium of $40, or let's say a monthly premium of $50 or $60, and you pay this much premium, but the service is more or less for the same as Medicaid. Okay, the service is the same as Medicaid, because what happens is you have to have a health insurance if you are doing a job. Okay, if you are doing a job that is at least more than $24,000 per year, that is more than $24,000 per year, then you are liable to pay money to health insurance over here in USA, no matter what you do. Okay, so if you want, you can pay 900 for PPOs, but most people would obviously want to pay less. That's that. Next one is point of service. Point of service is a bit more than HMO. Okay, and they are a bit less than PPO. That's what it is. So that is point of service. Can you please give me 1 second, please? I apologize. Okay. So the next thing I want to talk about is point of service. Point of service is basically your premiums, where it will be a bit more than HMO, but a bit less than PPOs. Okay. So the thing is the only advantage of having a point of service is, so do you guys remember we talked about in-network providers and out-of-network providers? So let's say there are a lot of health insurance companies. Okay, we have Affinity, we have United, we have Empire Blue Cross Blue Shield, right? Health First, and these are all. So every insurance company is associated with their network provider. Okay, so let's say Dr. Hyderi works for, or Dr. Hyderi accepts Affinity. Then let's say who do we have? Let's say we have Dr. Tarin, Dr. Harry, Dr. Nikki. Okay, then all these are the doctors. Okay, and let's say you guys work for United, and let's say Dr. Haidari, Dr. Adhanom, Dr. Hussam, Dr. Karbasi, and we all work for Affinity. Now we have John over here. Okay, John specifically wants to go to Dr. Harry. Okay, John specifically wants to go to Dr. Harry over here. And now the thing is, if John has an HMO, okay, if John has an HMO and John's primary insurance plan is Affinity, okay, can John go to Dr. Harry? Yes or no?
Yes, why not?
No, he cannot go. Okay, that is the problem. Because if you have HMO, then you have to go to in-network. You have to go to the doctors who are there in your insurance plan in Affinity. That means if John has Affinity, John has to come to Dr. Haidari, Dr. Hossam, Dr. Adhanom, Dr. Karbasi, and then John has to come to these doctors. So John cannot go to Dr. Harry. Okay. Right now, if let's say let's say now John has point of service, POS, point of service. Can John go to Dr. Harry right now?
Yes.
Yes, right now, John can go to out-of-network providers. Out-of-network provider. That is the only advantage, that John can choose whoever he wants to go to. And if John has PPO, can John go to Dr. Harry, Dr. Tareen, all
Yes.
the other doctors? Yes, John can do whatever
Then go.
John wants, because John is the king of the health insurance plan. Okay. John can do whatever John wants. He can make an appointment with a specialist. He can make fast appointments, slow appointments, or do whatever he wants to do, but that's what it is. Okay, but keep in mind, it does not matter how much money you pay. Okay, USA will always make sure that every patient is treated the same way. Okay, that is another thing though. It's not like that you pay a lot of money, you go to the hospital and you're treated like a king. It's not. You will be treated in the same way that anyone else is treated. So that's the best thing about it. The only thing.
But can I ask two questions?
Yes, go ahead, please.
Like for example, in Germany, like we have two types, like the general one and the private one. And if you want to go to the private one, first of all, they do like a risk questioning, like they will ask you for previous diseases and so,
Mhm.
which you had, and then they're going to decide if they're going to take you or not. Is it also the same for PPO in the US?
Yes. Yes, it's also the same. Okay, it's also the same. I'm going to tell you why. Because if a person has a previous history of diabetes, hypercholesterolemia, this and that, and all these other problems, the person also needs surgery. Then an insurance company will decide whether to give them the insurance or not. Because this person will require a lot of hospital visits and a lot of surgeries and this and that. So that's something which they have to decide whether they will provide this kind of service to them or not, because they want to think about their profit more than your need of the hospital. Okay, that's what
So
business.
So PPO, HMO, and POS, they will think about that. And what is then Obamacare? What was like special about Obamacare? Like, I mean, if
Obamacare
you're
was for everyone, regardless of their job, ethnicity, immigration status, anyone. Obamacare cared about everything. You did not have to have a permanent residency. You did not have to have a citizenship to require Medicaid. Obamacare basically cared about everyone in the United States, regardless of their paperwork.
so like Europe. Oh, okay.
I'm sorry?
So like in Europe, it's like that. Like if you come
Right.
to Germany, no matter what, like as a refugee,
Mhm.
automatically you are
Yeah.
you have a health insurance.
Right. That's what it is. Okay. Are we clear about health insurance plans?
Yes.
Okay. 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 So if you guys need, can you guys please write this? Can you guys please, I don't know, just make a small note of this. I'm not sure where you guys will see this in first aid. Maybe in behavioral science or like get it, but
It
this
is
very-
in page 271.
Oh, perfect. Okay. So please, what was the page number once again?
271.
Okay, so
271.
please go to page 271, and then you can see the topic over there. Okay, but this is more easier to understand. Maybe I remember that page number, it's a bit difficult. Okay, but this is more easier. So please write them down if you get the time. Okay, next one. Having said that, we don't have a lot of time today. We're almost pretty close. Let's move on to the next question. Okay. Okay, next one.
Wait, what was the answer?
Sorry, what is the answer?
Oh, I did not.
A, right? A,
Oh,
right?
answer was A.
A.
Yeah.
Okay, the answer was A. Why was the answer A? The answer was A because she wanted to pay low income. She wanted to choose a low monthly premium, low monthly payment. So health maintenance organization. She is not qualified for Medicaid because she's working.
Yeah.
She is not qualified for Medicare because she is more than 65. She does not want point of service plan because it's more expensive. And obviously preferred provider organization is way more expensive. So HMO is the least expensive. Okay. Are we clear?
Yes.
Perfect. Okay. Next, this one. Let's go. Okay. Okay. If both patient requires blood products, which of the following is the most appropriate course of action? Okay. A 6-year-old girl and her mother admitted to the trauma center after sustaining blunt abdominal injury. Diagnostic lavage, peritoneal lavage is positive for blood in both patients. They have a clouded sensorium, neither response to questions. Okay, the physician contacts the woman's husband. Oh, this is a very famous question. Okay, the physician contacts the woman's husband who informs that they are Jehovah's Witness. Okay, so what is Jehovah's Witness? Does anyone know what that means?
Yeah.
They don't,
Yes, they don't
there is
accept
a
blood transfusion.
Okay.
special belief. No.
Right. It's a special belief of it's a special type of belief where they cannot receive blood transfusion. Before the physician Before the physician can rely any specifics about the family's condition, the father hangs up the phone and repeated attempts to contact him are unsuccessful. The woman and her daughter carry no documentation, blah, 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 and remain unresponsive. If both patient requires blood product, which of the following is the appropriate course of action? Okay, now can I get some answers, please?
Administer blood to daughter only.
Yeah.
Yeah, B.
C. C. C.
Yeah.
C.
To the girl.
Not
Is it not D?
Yeah, C.
Is it not D?
No.
no.
Administered, yeah, to the
Or even
girl
E?
only.
Okay,
It's
I will
C.
give you
L
guys,
to go.
Because
I
you
will
have to
give you
respect
guys-
them.
Okay, one second. I will give you guys 10 seconds. Read all of the answers and then provide me with one option. Take 10 seconds.
Yeah, it's C.
Okay.
Yeah, C. C.
C.
Okay. Administer blood products to the girl, but not the mother. Okay. Now,
Yeah.
my question to
I
you
would
is:
say D.
I'll say A.
do not administer blood products to either patient.
But the husband didn't say like if to give it to the wife.
Ah,
the husband didn't give the direction
okay.
as
Wait.
So you would give it
I'll
to
give
both
to both of
maybe.
them.
A is the answer.
A.
Yes, me too.
Okay. Good. Okay. Your time is up. Okay. Now. Okay. Okay. Now, what's going on over here is this question's about Jehovah's Witness. This is not the only question about Jehovah's Witness on UWorld. Okay. First of all, there is another question in Jehovah's Witness where the husband is present in the hospital. If someone cannot make decisions for themselves, who is the next in line to make the decision for that person?
The next of kin, the husband.
Yeah.
Husband.
Yeah, husband.
If the wife can make decisions for herself, the healthcare proxy over here is the next of kin, meaning the husband. After the husband, it should be the parents. If not the parents, then the child. Okay, so that's how it goes. But the husband is number one. But what's happening over here is the husband hangs up the phone and repeated attempts to confirm their religious belief. Repeated attempts to contact him are unsuccessful. So now the physicians do not know what to do. Okay. And the patient told the physician themselves that they are Jehovah's Witness? Yes or no?
No.
No.
Okay, for all the physician knows that the guy that they called could be someone that the guy hates. Like, let's say the physician called the husband, and let's say if it was not the husband who picked up, let's say it was someone else. Okay, how can the physician confirm that the guy who picked up is their husband? And let's say that someone else wants the wife and the wife and the child to be dead, and just tells the physician that they're Jehovah's Witnesses and don't give them any blood. So if the husband cannot confirm and the multiple attempts to contact him are unsuccessful, then the physician has to make the decision for themselves. Okay, because the physician cannot hear from the horse's mouth, from the mouth of the patient, or from the next of kin that the patient is Jehovah's Witness, because it is not specified anywhere on paperwork. Okay, having said that, what's your answer option?
A.
Okay, now your answer option is A, because you have to save the patient. Number one of medical, um, first of all, is you have to respect the patient's autonomy. Okay, that's a given. But right over here, the patient is not stating their autonomy, so the doctor can do what's right for the patient. Are we clear? Okay, good.
Yes.
Okay. Okay, what happened over here? 1 second. Okay. Why is this inverted? Okay, 1 second, please. Okay. Okay, I'm feeling very lazy right now. Do you guys really want me to get this out? Is it possible to read it with your necks a bit extended to the side?
No, no, sir.
Yeah,
It's
no
fine.
I
problem.
think if you right click it, you can
No
rotate
problem
it.
if it's not possible.
You can read it, please.
You can read it.
No problem. No problem. 1 second. I will upload this question once again. While I do that, okay, let's answer this question. Okay, let's answer this question. Okay, let's go. Which of the following is the most appropriate course of action? Okay, a 48-year-old male presents to your office as a new patient demanding that you sign a disability form so he can continue to collect a disability benefit without working. When you ask him what his disability is, he angrily retorts that his back is hurt as he slams his disability form in front of you. You feel yourself becoming annoyed by the patient's threatening behavior. What do you do as uh, as a doctor with a proper medical ethic? What should be done?
I'm going to claim him for patient that you cannot find this form because you will be able to care for him.
I'm sorry. Do we have a question, or
Be careful when you do that.
you guys are just reading through the answers? Okay. Okay, good.
E.
E.
Yeah,
Anyone
E.
else?
E.
Okay. Okay. Now let's talk about A. Inform the patient that he
Why
must
not
respect.
B?
I'm sorry.
I
What
said
was your-
I thought it might be B because like your own safety's at risk, no?
How? How is your own safety at risk?
He's acting very like
Yeah, but
angry.
he's not right. But he's not threatening to kill you. I mean,
He's not getting physical.
But
yeah,
he's slamming stuff down on the desk, no?
how? No, all
What if he
all
slams
he
your
did was all he basically did was he slammed his disability form in front of you, and that's what he did. So it was an act of okay. So basically, they also told you how you feel. They didn't tell you that you felt threatened. They told you that you felt annoyed.
Okay.
Okay, so they basically told you how you felt. Okay, so B is not the right answer. A is not the right answer. Inform the patient that he must respect you in order to continue to see you as his physician is not ethically correct. The patient has the right to respect or not respect you. That's the patient's right. Okay, you cannot ask the patient to do whatever you want to do, you want him or her to do. Exit the room and call the authorities to report the patient's attempt. Of course, you should do this. If you feel threatened, then you can do that. Okay, but over here, you're not threatened, you're annoyed. Calmly inform the patient that you cannot sign his form because you will be unable to care for him due to his abusive demeanor. You always have to care for your patient regardless of his demeanor. Okay, that's that. Patient is number one. Sign the patient's form because he is clearly suffering from a painful and limiting condition. The patient does not look like he's in pain, so that's that. So the correct answer is E. So very good. Okay, next one. Okay. Okay, this should be this should be easy for you guys. We just discussed about these things today. Okay. Which of the following is the most likely diagnosis? Okay. Okay, a 29-year-old woman comes to the office due to persistent fatigue over the last 4 years. She has also felt unhappy during the period ever since being let go from her job. The patient describes the fatigue as having little energy to do anything. Okay. When asked what she enjoys, she replied that everything in life is a chore and that she feels hopeless, that her life will improve. The patient has no suicidal thoughts, problems caused with no concentrations or changes in appetite or sleeping pattern. She uses marijuana and drinks 1 or 2 glasses of wine on weekends. Detailed workup and urine toxicology is negative. Which of the following is the most likely diagnosis? Look at the timeline, look at the criterias, and you can easily answer this question.
C,
D.
C,
C.
This are say
I'm
this
sorry.
D.
Yeah. D.
D.
time, yeah.
Okay. So, does anyone have C on their mind?
yes.
No.
Yes, I
Who?
do.
Yes.
Annie.
Why do you have C on your mind?
More than 2 years, more than 12 months.
Mm-hmm.
That's
No, I don't think it's gonna be D because that's milder than major depressive disorder, right? But she seems like pretty depressed.
How? She has no suicidal thoughts. She has no problems with concentrations or changes in appetite or sleeping patterns.
Yeah, the 5 criteria of major depressive
So
disorder are not
yeah, no
met.
suicidal. The only things that she has is she feels fatigued all the time, and she feels that she has a little energy to do things. That's what it is. And she feels like everything in life is a chore, meaning that she feels hopeless. But she has no suicidal thoughts or concentrations or changes in appetite. Now, what's your answer?
D.
Very good.
D.
Okay.
D.
Are we all on the same page with D?
Yes.
Yes.
Okay.
Yes.
Yeah, that makes more sense.
Okay. Perfect. Thank you so much.
Oh, please, I'm not getting it.
Okay. So let me repeat it for you. No problem. Okay. So first and foremost, before we do that, let's move on to this time here. First and foremost, who was the doctor who said she or she did not get it?
It's me, Nana.
Okay. If I ask you the definition or diagnosis of dysthymia, how will you define or diagnose a patient with dysthymia?
Um, Depression for more than 2 years.
Right.
That
Basically, you will have the depressive episodes for 2 years or more. Okay, and your episodes will not get resolved for a period of more than 2 months. Okay,
2 months. Yes.
but the depression will not be so severe enough that it will cause functional impairment, right? So over here, this is your exact patient with this type of problems. She is fatigued. She has little energy to do things, meaning that she has a loss of interest. Okay, she feels like everything is a chore. Okay, but at the same time, she has no thoughts of committing suicide, concentrations, or changes in appetite. So, and also since this has been going on for such a long time, that is for the last 4 years. Okay, this patient can be easily diagnosed as dysthymia, not major depressive disorder. Okay, because if it was a major depressive disorder, she would have had to have 5 of the 9 symptoms. Okay, she would have to have 5. Okay, out of those
Mm-hmm.
5, these things would also be there. Problems with concentration, changes in appetite, sleeping pattern, these things will obviously be there, or else it would not be 5.
Okay. Okay. I get
Okay,
it.
okay, you
Thank you.
are okay. You are welcome. Okay, okay. Give me one more second, please. Let me just get that one question again. 1 second. I'm sorry for taking so much time for you guys today. Okay. Okay. As a matter of fact, better yet, let me just get you another question. Okay. 1 second. Okay. Okay. So can you guys see my screen right now? Can you guys see the
Yes.
screen?
Yes.
Okay. So last
Yes.
question of the day. Thank you so much for having your patience and cooperation. Okay. Last question of the day. This is a very important question. Which of the following is the most appropriate response by the attending? Okay, so first of all, a 70-year-old woman is transferred from a community hospital for a high-level care of an acute exacerbation of blah, blah, blah. Okay, so none of this are important about the disease, keep in mind. She is cared for overnight hospital who transfers to a teaching service in the morning. The medical team responsible for the patients meets her for the first time during morning rounds with the attending physician. The patient addresses the intern by his first name and mentions, "You remind me of my grandson." The intern starts his interview by calling the patient by her first name and begins asking about her medical history. Which of the following is the most appropriate response by the attending physician? Okay. Okay, so what's going on over here? The intern starts the interview by calling the patient by her first name and begins asking about her medical history. Now, what do? You are the attending physician. You have an intern working under you who just addressed the patient by their first name.
B. I think B.
Mm-hmm.
Was it not D? D?
B.
B.
D.
I think.
Okay. The most common etiquette over here, the best way to avoid any type of
B.
conflict
B.
is to refer to someone by their last name.
Last
Okay.
Yeah, unless
Yeah.
you prefer
By the
from
last, every
address. Yeah.
person should be referred by their last name, but that's the commonest etiquette. Okay. So the patient has to be addressed by her surname and ask her preferred form of address. Like after you ask her, let's say her name is Jane Johnson. Okay. And you ask her, okay, Miss or Mrs. Johnson, would you mind if we address you as Mrs. Johnson? And then if she tells you no, it's perfectly okay, then you can keep on addressing her as Mrs. Johnson. Or if she goes like, yeah, no, I'm good with you guys calling me Jane, you guys could just call her Jane. As simple as that. Okay, but at first she should be addressed by her surname. Okay, that's what it is. Okay, having said that, that's all for today. Okay, thank you so
Thank
much.
you so much for the day.
Okay, you are
Yeah.
welcome.
Thank you, sir.
Okay, you are welcome. Please answer my question about Jehovah's Witness. Okay. Jehovah, can you explain more? Of course I can. First and foremost, what is Jehovah's Witness? Jehovah's Witness are groups of people who do not want blood products in their body, which are
Go sit down.
outside, which are infused
Come
from
sit here
outside,
so you can eat.
which are infused from outside. So what happens is this patient over here who has been admitted to the hospital, the doctor tried contacting her husband, but the husband said that she is Jehovah's Witness, but the husband's line was cut. So the doctor could not confirm the fact that she was a Jehovah's Witness, and the husband was not there physically to confirm that. So the doctor had to do what the doctor had to do, that is to save the patient's life. So the doctor infused the blood. Are we clear, Dr. Ahmed? Okay, so hopefully this should clear everything off. Okay, if you have any other further questions, please let us know in our email and we will try to break it down for you. Okay, again. Okay. And okay, everyone, you guys are welcome. The lectures will not start from 9:30 anymore. Okay, they will start from 9 a.m. as usual. Okay, today was just an exception because there was something I need to take care of regarding my father. Okay, so that's that. So that's why the lecture started at 9. Okay, are we having lecture this Thursday? Yes, this Thursday is Thanksgiving. Okay, over here in USA, but this will not affect our lecture because we will still have our lectures on due time. Okay, we will still have our lectures from 9 to 2. Okay, so that's that. Lecture 19. Okay, give you. Okay, we will provide the today's lecture for you guys, so do not worry. Okay, so hope you guys have a great day today. Okay, if anyone is left to complete the transaction, please try to complete it by today or tomorrow. If anyone has sent us email for emails for their extensions, that's not a problem. Okay, extensions can be given as that. And to all the students who has not sent us an email for extension, uh, did you get mine, Dr. Ghazi? Okay. What? So what is your email address? Oh, okay. Dr. Salim. Okay, yes, I got yours. Thank you so much. Mhm. Okay, I got yours. Okay. So thank you. That's that. Okay. So hope you guys have a great day today. And if you have any questions, let us know in our email. And with that being said, we will take off and see each other tomorrow at 9 a.m. Thank you so much.